this computer. Okay. እሺ እንዴት አመሻችሁ? Good evening, guys. Yeah, እንግዲህ just for the sake of some individuals who might not be understanding Amharic, I'll do the presentation entirely in English as much as possible, but here and there I may, be forced to use Amharic. So try to engage with me in English as much as possible. So you know me, most of you, for one way or another. I think you know me now. So my name is Fakada Selassie. So trained cardiothoracic surgeon, currently practicing as a board certified internist in the US. So today's presentation is going to be our episode 4 of a part of our project called Website with Dr. FSH. So I will be presenting the case. So like always, we will start with the chief complaint. So this is a chief complaint of our patients for today's discussion. So worsening in abdominal girth over the past 2 weeks and confusion over a period of 1 day. This patient was brought to Korea Hospital. Now give me differential diagnosis. So worsening of abdominal girth over the past 2 weeks and confusion over the past day. Came to Korea Hospital. What comes to your mind?
Cirrhosis.
Cirrhosis. Cirrhosis is what?
Fibrosis of the lung tissue.
So you better call it decompensated.
With the
I'm helping you. So decompensated cirrhosis, or you can decompensated chronic liver disease, you can say, or cirrhosis with ascites, right? Because ascites is a sign of decompensation, right? So when a chronic liver disease decompensates or when cirrhosis decompensates, they tend to develop ascites or worsening of ascites. Okay, so but what are the differential diagnoses for chronic liver disease? What etiologies do you know? Because this is like a broad terminology. Chronic liver disease or cirrhosis can result due to various reasons. So can you give me some examples which might result in CLD, chronic liver disease or cirrhosis?
Alcoholic liver disease.
alcoholic liver disease.
Go ahead. So
viral hepatitis. Non-alcoholic.
Non-alcoholic. I'm not listening. I don't hear you. Non-alcoholic fatty liver.
Viral hepatitis.
What kind of viral hepatitis?
Hepatitis B.
Chronic hepatitis. Chronic viral hepatitis. So most importantly, hepatitis B virus and what? Huh?
Hepatitis C.
Yes, hepatitis B, hepatitis C. Okay.
Biliary cirrhosis.
Yeah, primary. Uh-huh.
There are a few more differentials in the chat box. Should I say?
Yeah. Tell me, yeah.
Hepatic schistosomiasis.
Schistosomiasis.
Budd-Chiari syndrome. Autoimmune diseases.
Autoimmune hepatitis. Yes, አንብቢልኛ አለ ሌላ
Okay. There is also uh, leishmania.
leishmania.
Yes.
Leishmania actually is present with, massive splenomegaly than cirrhosis, right? So it's visceral leishmaniasis. Most of the time it presents with massive splenomegaly. So that's less likely. Other causes.
Cardiac cirrhosis.
Okay.
And also Wilson's disease.
Huh?
Wilson.
Wilson's.
And hemochromatosis.
Primary. Primary sclerosing cholangitis. What else? What else?
Hepatocellular carcinoma.
Hepatocellular carcinoma as such, yeah, it can present with, okay, let me take it, hepatocellular carcinoma, but okay.
There is also drug-related hepatitis. Drug-related hepatitis. Like
So that is going to be acute.
acetaminophen.
That's going to be acute liver failure then, right?
Yeah.
So that is going to be another differential diagnosis. So
Alpha antitrypsin deficiency was also mentioned in the chat box.
okay. Alpha 1. እሺ So the list is long, so, decompensated CLD, cirrhosis, like causes of cirrhosis or like, chronic liver disease, the list is very long, as you see. It's not even, comprehensive, but at least these are some of the commonest ones. So we shouldn't really be wasting our time, listing the rare diseases, but, alcoholic liver disease is very common, non-alcoholic fatty liver disease is very common, especially in the West with obesity. Chronic viral hepatitis could be very common in, developing nations like Ethiopia with hepatitis B virus, high incidence of hepatitis C virus infections, primary biliary cirrhosis, primary sclerosing cholangitis, cardiac cirrhosis, Wilson's. What is Wilson's disease, by the way? What's Wilson's disease?
Excessive accumulation of copper in the body.
Excellent. So including the liver, right? So it destroys the hepatocytes. What about hemochromatosis?
Iron. Excessive
Yes.
accumulation of iron.
Iron in the liver, and that destroys the liver function as well. Hepatocellular carcinoma, of course, we do see it in the background of, chloric liver disease, especially those patients with hepatitis C virus, hepatitis B virus, especially like even if you treat it or not, hepatitis C virus is a notorious one actually in predisposing patients to hepatocellular carcinoma. So in the setting of chronic hepatitis C virus or hepatitis B virus infections, those developing hepatocellular carcinoma may come with like, worsening ascites and all that. And schistosomiasis is very common in the developing nation, especially those people who are working on irrigation. Burkieri syndrome. What is Burkieri syndrome? What is Burkieri? So occlusion of the hepatic veins. Yes. So like, post-hepatic exclusion, obstruction of hepatic vein. Yeah, so hepatic vein thrombosis and closure by a clot can result in, Burkieri syndrome, autoimmune hepatitis, alpha-1 antitrypsin deficiency, and all that. All these are, causes of cirrhosis. So this patient, we don't know whether this particular patient has these illnesses in the background and then eventually develop cirrhosis and eventually become decompensated, resulting in worsening in ascites, and that leads to, increase in the abdominal girth over a period of 2 weeks. So that's one possibility. So what other conditions can result in increase in abdominal girth? Acute liver failure, medications like medication overdose, like acetaminophen is one reason. Okay, what else? Other differential diagnosis other than cirrhosis.
Gynecological conditions
Like what?
like ovarian tumor.
Ovarian tumor, okay. Excellent. But I will kill you. Oh, I shouldn't kill you because I didn't tell you the sex of the patient, right? Okay,
I think that's why they mentioned it.
let's keep ovarian tumor. That's fine. I didn't tell you the sex, so you are good. Go ahead.
Pregnancy.
Pregnancy. Okay. Okay. What else?
Renal conditions like nephritic or nephritic syndrome. Nephrotic or nephritic.
Nephrotic syndrome. Okay.
Organomegaly.
Organomegaly like what?
Hepatosplenomegaly.
Okay. Hepatosplenomegaly by itself is going to be a huge differential diagnosis. Long list of differential diagnosis. Bear that in mind, okay? Because hepatosplenomegaly can be due to multiple factors. So you can think about that if you find out hepatosplenomegaly on physical exam. So you can think about that. Okay. What else?
Tuberculosis.
What kind of TB?
Intestinal.
Disseminated TB or intestinal TB with ascites, okay.
Congestive heart failure and intestinal obstruction were also mentioned.
Congestive heart failure. So guys, be systematic. So what are the systems which are going to be affected? So when the heart is affected, we can get mute አድርጊልኝ ሜላቴ የት ነው ያለሽው ለመሆኑ? ሜላት
I'm sorry, background. Hello.
የት ነው ያለሽው?
ውጪ ነኝ ያለሁት። ይረብሻል ባክግራውንዱ?
ኖ ችግር የለው። ትንሽ ይጮሃል። ስትናገሪ ብቻ ክፈችው። ችግር የለው።
እሺ እሺ።
When you are mentioning the differential diagnosis, always you have to be systematic. Like, okay, what can result in ascites, for example, or what can increase abdominal girth? So, for example, if it is ascites, you can think, things related to the heart. So, congestive heart failure. What can result in congestive heart failure? The list is going to be long. So, congestive heart failure is one differential diagnosis. What other heart condition can result in ascites, for example? Even staying within the cardiovascular system. Give me another differential diagnosis.
Dilated cardiomyopathy.
Cardiomyopathies in general.
Constrictive pericarditis.
Excellent. Constrictive pericarditis. What else could it be? I think ልቁረጠው ይሄንን ነገር ሌላ ፔጅ ላምጣለት. That the list is so long. Wow, impressive. Okay, constrictive pericarditis. What else? Right-sided heart failure, right? Right-sided heart failure of any reason. It could be of any reason. Like, you can have cord pulmonale here, constrictive pericarditis. core pulmonale, right-sided heart failure. Then, like, if you are thinking of the kidneys, most importantly, nephrotic syndrome is remarkably involved in the anasarca or ascites or whatever. Okay, what other pathologies can give you? Liver, already you told me. In line with liver, what else could be a reason for worsening ascites? Hmm? During cirrhosis, during the compensation, there will be hepatic failure, right? One of the functions of a liver is synthetic function, right? It produces.
Hypoalbuminemia.
Yes, I'm trying to go there. Yes, hypoalbuminemia. Hypoalbuminemia could be due to what? Due to nephrotic syndrome, due to liver failure, or it could be also due to what?
Protein losing
Protein-losing
enteropathy.
enteropathy.
Yes, protein losing enteropathy, or it could be due to malnutrition, right? Protein energy malnutrition, severe protein energy malnutrition. Or the malnutrition that could be due to protein losing enteropathy, or
Spontaneous bacterial peritonitis.
yeah, let me finish this. Protein losing enteropathy versus poor intake. Okay, what did you say?
Spontaneous bacterial peritonitis.
SBP. Okay, you want to consider SBP. Okay, what else do you want? Complications which might happen in a patient with decompensated cirrhosis. Okay, SBP is a possibility. What else? Then we'll challenge.
Hepatic encephalopathy.
Yeah, there is confusion. Excellent. There is confusion. Hepatic encephalopathy. What else?
Hypothyroidism.
Hypothyroidism wouldn't as such result in, belly size increment in confusion, so less likely. What else could explain the confusion of this patient? You said alcoholic liver disease, right? What can confuse the patient?
Intoxication.
Chronic encephalopathy.
Intoxication versus what?
Wernicke encephalopathy.
Intoxication versus what?
Withdrawal.
What else could? Withdrawal, excellent. Alcohol withdrawal, alcohol intoxication are possibilities in this patient. So you see the list is long. We have a very long list of differential diagnosis in this patient. So let's proceed with the rest of the stuff. Okay, so now we have a very long list. If anything comes up to your mind, you can add it later on. Let me give you a little bit of details, and then we'll try to narrow this differential diagnosis. Okay. So here is a patient. So the patient's name is FSH, Solomon and whatever. Age is 56 years old. Sex is male. His married occupation is his long distance driver. Okay, now ask me what informations do you want to ask about this patient? Okay, now we are at the stage of HPI.
Sexual history.
Sexual history is very important, but guys, stick to basic principle. So when you are elaborating the history of present illness, what do you do first? What is a basic principle? Not Nile, what is a basic principle? You elaborate, right? Before you go to associated factors, risk factors, whatever, you try to elaborate the chief complaint, right? So can you guys try to elaborate the chief complaint?
First, we should know the duration of the chief complaint.
So the duration is 2 weeks. Okay, the abdominal girth was gradually increasing over the past 2 weeks, and he became confused earlier to his presentation.
Then an onset of the, okay, gradually. if there was a relevant or aggravating factor.
And nothing identified actually. I mean, this guy had alcohol history for the past maybe more than 20 years, and he stopped about a year ago. But recently, about a month ago, he started drinking again. So probably, I don't know if that is, predisposing. We don't know. Inciting event could be that one. That's one thing which I can tell you. Mm-hmm. ኧረ ጠይቁ እንዴ! ሆዴ እየተነፋ መጣ ሲል አንድ ሰው ምን መጠየቅ እንዳለባቸው አታውቁም እንዴ?
There are
መሰረታዊ
asking about there are questions on the chat box about characterizing the swelling.
Yeah, so it was a gradual,
ሰማለህ?
gradual worsening in the abdominal girth. Just my abdomen started increasing gradually, and my trousers are no more fitting me, right?
Okay, and another question, associated symptoms.
Yeah, you can ask.
If there were an associated symptom.
What do you mean
Like
associated
bleeding?
symptom? I am a patient, so I don't know what is meant by an associated symptom. So you have to specifically ask me the question.
Like if
Okay, bleeding. If there is a bleeding, melena was that?
What is melena, doctor? I don't know what melena is.
Stool color change.
No, I don't have any stool color change. It's brown.
If there is bleeding.
Bleeding from where?
Upper GI bleeding was also.
What is upper GI bleeding, doctor? I'm a patient right now. You are not talking to Dr. FSH right now. You are talking to SH, a patient named SH. So I'm representing the patient. So ask me questions as if you are talking to a lay person who is your patient in Korean hospital emergency department. Okay, so be specific. Know the questions you should ask, okay?
Is there any yellowish discoloration of skin or eyes?
Yes, my eyes have become yellow the past couple of weeks. And I also, people also tell me that my skin is also somehow yellow. ቅድም የተባለውን እኮ ወርድ ጠይቃችሁ እኮ መጠየቅ እኮ ነው። በዛው ጥላችሁ ሩጡ ማለት አይደለም። ብሊዲንግ ፍሮም ዌር ስል አልገባኝም እያልኩ ነው። ሰው እንዲገባኝ አድርገሽ ጠይቂ ማለት ነው። when you say melena, when I say I don't know melena, you don't run away. You explain that to me in a word I understand. So don't look for another questions. Just you have told me, elaborate that in a layman term ነው point because you are also practicing on how you are interacting with the patient, okay? You are not only participating in a website. You are learning and practicing how to communicate with your patients with a similar complaint, okay?
Meeting.
Eh?
For the upper GI bleeding, bloody vomiting if he had bloody vomiting.
No, I didn't have any vomiting at all.
Did you have any right upper quadrant pain? ወይም በስተቀኝ በኩል
I don't have right upper quadrant. It's fine. I understand English. So just speak in English, but ask me in a way a lay person who understands English would understand you, okay? So yeah, I don't have any abdominal pain. Actually, you should say stomach pain or belly pain. Even here, right upper quadrant, lower upper quadrant, epigastrics, I don't understand, even though it's a primary language. So we ask them, do you have stomach pain? Do you have belly pain? Okay, that's how we ask them, even in English, okay? Okay.
Is there any associated itching?
Yes, I do have itching all over the body, especially I couldn't sleep at night. I noticed the yellowish discoloration about a week ago. So my eyes, I realized that they have become yellow about a week ago. I don't have
Is,
fever.
is there a stool color change or urine color change?
Yeah, my urine has become somehow dark. It looks like a Coca-Cola. So you should ask me specifically, give me an example. When you talk about urine color change, you should say, did the color of your urine change? Does it look like a tea? Does it look like a cola color? So you have to give them, you have to guide them. Then they would say either yes or no, okay? Because they don't know what you are specifically trying to understand by asking changing the color of the urine, okay? So be specific in your questions. So yes, I do have a urine color change and it looks like a Coca-Cola. Now my stool is brown, no change in the color of my stool. Yes, I do have fatigue. I easily become so tired. I'm always tired. I feel fatigued and I have lost my appetite. I'm not eating well the past couple of weeks.
Is there any herbal medication intake?
No, I didn't use any herbs. So when you are asking questions, let me give you an example, a hint. When you are asking questions as part of your history of present illness or HPI, remember the list of differential diagnoses you have already outlined. So you have a very long list of differential diagnoses here. So you have to ask at least one key question which would help you to exclude it or to include it as part of your differential diagnosis. So bear that in mind, okay? Bear that in mind. Okay, go ahead.
Family history of
No family
similar
history.
illness?
No family. Nobody in my family has such a problem. No, I don't have orthopnea. What's orthopnea, Dasali? I told you multiple times. What is PND? You have to tell me in a language which I understand. Orthopnea is technical. PND is technical. You don't use technical terminology in HPI. HPI is the word of the patient, not your interpretation. Patient tells you a complaint, you can interpret what it means. You can translate it into your technical terminology later on. But you don't use technical terminology when you are writing your history of present illness. Okay, that's a big no. If I evaluate your history, if I evaluate your case report, I will give you a big X if you use technical terminology in HPI. Okay. How many pillows? Excellent. So I do use just one pillow, but the problem is my shortness of breath. Oh, you didn't ask me about shortness of breath. So no, I'm not. I am using one pillow. Alcohol intake, I used to drink about 4 cans of beer a day. And on top of that, I used to drink half a pint of vodka. And I did that for over 20 years and I stopped about a year ago. And unfortunately, I relapsed last month.
Difficulty of breathing was also asked.
Yes, I do
If
have
there was a
shortness of, I do have shortness of breath. And in the past, my shortness of breath was with activity, but nowadays, even at rest, while I am sitting and sleeping, I do have significant shortness of breath. The yellowish discoloration is getting worse. So when I am lying flat, I am fine. But when I am sitting up, I do have my difficulty of breathing worsens when I am sitting upright. It's strange, right? It's strange. When I am sleeping, I am relatively okay. That's fine. But when I am sitting up like this, my shortness of breath gets worse. My appetite is very poor. Be a good listener, guys, because I talked about appetite and don't ask patients the same question because they would assume that you are not listening to them and they get distracted. They become less interested to talk to you. So always when a patient gives you an information, try to be attentive and don't repeat the same question, especially if they have answered it already. Okay? No
any other
diarrhea.
body swelling.
I don't have diarrhea. Rather, I had constipation over the past 2 weeks. No positional change in my swelling of the belly.
Is there any other body swelling other than the abdomen?
Yes, my legs are swollen as well.
Have you had any river water contact recently?
No. I live in this. I am a long lorry driver, but like I have never been to any water body. Water contact ነው ያልሽው? How did you ask it? Can you say it again, please?
River water contact.
River water contact. No, I don't know.
Have you ever been transfused with blood?
No, I have never had any blood transfusion. Excellent. Beautiful question. No, I don't have any tattoo. I'm against it. Yes, I had multiple sexual partners, and unfortunately, I was not using protections. When did the confusion start? That was the first information I provided, guys. User, please change your username so that we know who you are. Number two, and that information was given as part of the chief complaint. The confusion started last night, about a day prior to my presentation.
There
Ask
was
more
also a
questions.
question about the sleep pattern. Is there a change in the sleep pattern?
Yes, my sleep pattern is affected. These days I was struggling to sleep. No abnormal body movement. Excellent questions, by the way. Just ask as many questions as possible, which are relevant to exclude differential diagnosis. Then later on, we will find it very easy to kick off most of the differential diagnoses from the list, because the list is scary and we have to really narrow it down as much as possible, okay?
And about the alcohol history, there were more questions about
Okay.
have you used it as an eye opener?
In the past,
Have
yes.
you,
In the past, yes, but not anymore. I stopped about a year ago. Only about a month ago, I relapsed.
do you think of cutting down, or do you feel any guilt?
Yes, I feel guilty about it, and I was trying to stop, but unfortunately, for some reason, I was a little bit depressed. I had a family issue, and then I started drinking again. I was trying to abstain as much as possible. And yes, I lost some amount of weight, but I don't know how much I lost. No,
There was
not
also a
that.
question about
No, that is haram. I don't use any IV drug use. No IV drug use. Yes, I used to consume daily. I told you, I used to drink daily. I told you how much I used to drink. I told you for how many years I drank, and I told you when I quit. I told you when I started again. So don't repeat the same question, guys.
about the leg swelling. Did it come before or after the abdominal swelling?
I mean, the swelling was there. It was okay, but like, over the past 2 weeks, it got worse. I mean, it's increasing with the belly size, with the belly size. The guy who asked PND, he disappeared. በዛ orthopedian አብራራ. What about PND? What is PND, doctor? You asked me one question. I'm curious about it. What do you mean by PND?
He actually answered the question.
Mhm. How did she answer it?
He said, do you wake up 2 to 3 hours after sleeping during night because of shortness of breath?
No, that is not PND. አንደኛ ታይም የለውም። 2 to 3 hours የሚባል ህግ የለም። PND can happen anytime. How do you describe PND? Paroxysmal nocturnal dyspnea. What does it mean? You wake up from sleep gasping for air, right? So you feel short of breath, you are choking due to hypoxia, and then you wake up, air hunger. Some people, they may go to the window and open the window. just remove their blanket and all that. They are just fighting for their life because they are hypoxic for a couple of seconds and they wake up all of a sudden. So waking up all of a sudden from sleep, gasping for air is the right terminology. በአማርኛ ከእንቅልፎት ድንገት አየር አጥሮት መተንፈስ ቸግሮት ይነሳሉ ወይ ከእንቅልፍ በርግገው እና ወይ መስኮት ለመክፈት ወይም አየር ለማግኘት ይሞክራሉ ወይ እንደዚህ አይነት ነገር። If that has happened multiple times, they will say yes. If it doesn't, then they will tell you no, never. So I never had that issue. What else do you want to ask?
Your nutrition or diet history?
I
Nutrition
mean,
or diet.
dietary is like any other Ethiopian. I usually eat injera with what? Sometimes I consume pasta and macaroni. Sometimes I eat meat-based food. But the problem is over the past 2 weeks, my appetite was significantly low and I was not eating much. Any problem? What do you mean by Benny? Can you elaborate? What do you mean by any problem talking or walking? What do you mean? Or are you talking about aphasia or dyspepsia or anything like that? Benny, Benny. How do you say your name? Do you take any medication? Yes, I do take a blood pressure medication. I take amlodipine 10 milligram daily. So one differential diagnosis is medication related. And that is actually, we'll talk about it later. Medication related, not for the ascites, but for the leg swelling, most importantly. Okay. I don't take any other medication, no acetaminophen or anything. No, we'll talk about diabetes. Yes, I am type 2 DM. I have type 2 diabetes. What does cerebellar symptoms means? You are talking to a patient, Benny. So what are those cerebellar symptoms? Ask me those questions, then I will answer them. I don't know what a cerebellum is. Is the cerebellum in the leg, in the belly, in the chest? Where is cerebellum? And what are its symptoms associated with its pathology? Okay, so Melat, shall we progress? I think we have, reasonably asked the most important questions. Shall we progress?
Yes, there is one more question. How long have you been diagnosed with hypertension?
I don't remember. I'll tell you. I'll tell you. I don't want to change the subject. I'll tell you. I don't, yeah, I will tell you. I think 10 years or something. I don't remember exactly.
And also,
Mhm.
urine out, change in urine output.
My urine is okay. I mean, it didn't increase. It didn't increase. I'm fine with that.
Okay, I think there is no more questions.
Okay, good. So let's see what the patient does have. So, and then we go from there. So I came with gradual increase in abdominal girth over a period of 2 weeks. I became confused a day prior to presentation. He was brought to Korean hospital, endorses his belly size was increasing over the past year. You see, this part you didn't ask. So the belly size was increasing over the past year, but it became remarkably increased over the past 2 weeks. Okay. And family report, that tells you something. So that tells you what is going on because this problem, probably he had ascites, you never know, for about 8 months, 10 months, whatever. But over the past 2 weeks, remarkably increased. Family reported that he had disturbed sleep for 2 days and become increasingly confused. Over the past 24 hours, complaints of shortness of breath, even at rest. Shortness of breath worsens when he sits up. He endorses early satiety. You didn't ask me about that. So you guys who have been talking about organomegaly should ask about early satiety because if this patient has hepatosplenomegaly, that can potentially compress the stomach, compromises the stomach capacity. Then patients might experience early satiety. You didn't ask me about nausea. I mean, you asked about vomiting of blood. You didn't ask about nausea and vomiting. So I have nausea but no vomiting, has lower extremity swelling, gradually increasing over the past months as well. And other symptoms, endorses yellowish discoloration of the eyes and the skin with associated pruritus all over the body. Endorses easy fatigability, generalized weakness. You didn't ask about that. Decreased appetite, you did. Recent significant weight loss, you have asked it. Endorses a recent decrease in his sexual desire with erectile dysfunction. You didn't ask about this. Cola colored urine, you asked about it. Denies chest pain, orthopnea. You didn't ask about chest pain. You asked about orthopnea and pain. No hematemesis or melena. Okay, so no vomiting of blood or no rectal bleeding or dark stool. So that's how you say it. Okay. Gave history of significant alcohol history. So alcohol history now should be part of the HPI because it's relevant to the subject matter. Since the age of 30, he's 54, almost 24 years. He used to drink about 4 cans of a beer, half a pint of vodka almost daily, stopped about 10 months ago. Unfortunately, he started drinking alcohol about 2 months ago. The last time he had a drink was about 2 weeks ago. That is also very important. You didn't ask about when was the last drink. That is important. Why is that important? Can you elaborate? Why is that important?
Withdrawal
You
symptoms.
mentioned withdrawal.
Yes. So one of our differential diagnosis was withdrawal. So like, if the last drink was 2 weeks ago, then withdrawal is going to be less likely, right? In this particular patient. And the other differential diagnosis was alcohol intoxication. So alcohol intoxication would be automatically kicked out because, this patient's last drink was about 2 weeks ago. So intoxication is out. No injection drug use or use of recreational drugs, no history of smoking cigarettes. He is sexually active, had multiple sexual partners in the past. Okay. So past medical history could be part of sometimes the HPI. In this particular patient, unfortunately, you haven't asked me about diagnosis with hepatitis C, hepatitis B. That's very important, especially since I have mentioned that I had multiple sexual partners with no protection. Then you have to include whether I had a diagnosis of hepatitis C or hepatitis B in the past. In this particular patient, yes, this patient was diagnosed a couple of years ago with hepatitis C virus, and he was adequately treated and was declared cured. Okay, you get it? Do you get it?
Yes.
Yes.
Yeah, that is very important. Okay, so I have no GI symptoms other than the nausea and early satiety. No, I'm sorry. I'm going to change this. I have a constipation. I told you that I have GI symptoms, right? So some of the GI symptoms are mentioned in the HPI, but as part of the review of system, you can also elaborate further. But constipation. I have constipation. Last bowel movement was 5 days ago. Okay, that's very important. Why is that important, by the way? Why is it relevant? Last bowel movement.
Intestinal obstruction as a complication, maybe.
Yes, intestinal obstruction. The only thing against intestinal obstruction is the fact that this patient's presentation is 2 weeks. So most of the time, patients with acute intestinal obstruction, they present to you acutely, right? Within a day or two, unless they delay their presentation for many reasons, okay? Unless they have partial intestinal obstruction. Even with partial intestinal obstruction, they kind of present early. They won't wait for 2 weeks. Okay, so that's against it. So I'm not looking for intestinal obstruction. What else?
As a precipitant for hepatic
It can
encephalopathy.
precipitate hepatic encephalopathy.
Excellent. So constipation can potentially precipitate hepatic encephalopathy in a patient with cirrhosis. If a patient has CLD, chronic liver disease, cirrhosis, with ascites, it's a decompensated cirrhosis. Plus, if a patient is constipated, they may end up developing hepatic encephalopathy. So that is very important. That's why you have to know whether they have a bowel movement or not. Okay, it's relevant, and this history has to be taken in as part of the HPI. No urinary complaints except colored urine, which he noticed recently. Okay. Past medical history, has history of hypertension, diagnosed with hypertension 5 years ago, currently taking amlodipine 10 milligram. History of diabetes for 2 years on metformin, history of treatment for hepatitis C infection, declared cured, okay? Past surgical history is negative. No past surgical history. No smoking, alcohol, I told you. Recreational drug, I told you. Sexual history, we included it as part of the HPI, so we can kind of pass it, okay? And then now it's time for narrowing our differential diagnosis, okay? So we will narrow our diagnosis based on the history we got. So do you guys still have questions? Do you guys have questions?
There's no more question in the chat box.
Okay, good. So we'll start narrowing the differential diagnosis. Copy ማረገው ያንን የያዝነውን ዲሊት ማድረግ እንዲያመቸኝ ነው። እዛ ጋር based on what we have, we will narrow them down, okay? And that is going to be depending only on the chief complaint and the HPI we have. ከዛ ደግሞ ፈርዘር ዳያግኖሲሱን እናጠበዋለን በፊዚካል ኤግዛሚኔሽን ላይ ተመስርተን። Okay, let's narrow. አሁን ከዚህ ላይ የምትቀንሱትን ቀንሱ። Decompensated CLD, cirrhosis with ascites, which one do you want to keep on this patient? Alcoholic liver disease? Yes, we keep it. Non-alcoholic fatty liver disease?
Viral hepatitis?
No. Do you want to keep or remove? I am asking you. Non-alcoholic fatty liver disease. Do you want to keep it or remove it?
Remove it?
No, I mean like it may have a component. You don't know. This patient has diabetes. He may have, what is known as metabolic syndrome. You never know. This patient might be obese. You have no idea. So let's keep it for now, okay? Chronic viral hepatitis. Shall we remove it or keep it?
Keep it?
We keep it. At least, the patient has been cured, but the damage might have happened, right? So he is cured of the viral infection. The viral infection is cleared, but, the cirrhosis could be there due to that infection. So we still keep it. Okay. Primary biliary cirrhosis?
Okay.
Huh? Less likely, አይደለ? ብናወጣውም እንችላለን. I think, we have to do a couple of tests to exclude them. But, we have good enough reason to explain what's going on. So I think we can kick it. Primary sclerosing cholangitis. This patient was supposed to have jaundice for a long time, right? So the jaundice happened over the past week or so. So it's less likely, right? Cardiac cirrhosis.
Remove.
Why do you want to remove cardiac cirrhosis?
He doesn't have any signs of cardiac symptoms.
No, he has shortness of breath. He has
heart
ascites.
failure.
No, he has ascites. He has lower extremity edema. He has shortness of breath. All can be explained by congestive heart failure, right?
Oh, yes.
So we have to still keep that one. Wilson's disease, we can keep it if you want to, and we can exclude after investigation is done. Hemochromatosis, the same thing. We can keep it and we can exclude it once we do lab investigation. Hepatocellular carcinoma,
Keep.
we still keep it because we never know what's going on. Hepatocellular carcinoma could be there. So we'll exclude it when we do imaging. Schistosomiasis. Schistosomiasis.
Remove.
Remove. Why do you want to remove it?
History of river contact with acid.
No. Yeah. Excellent. No contact with fresh waters, right? Berchiari syndrome. You told me the pathophysiology. It's hepatic vein thrombosis, right? So shall I remove it or shall I keep it? Not 9.
We better remove it because its presentation would be more of acute if it was Burkitt syndrome.
But Chiari syndrome could be the reason why this patient further decompensates, because patients with CLD with hepatic failure, they have a tendency to form a clot and all that. Then this patient, they have a tendency to bleed actually, but this patient might develop hepatic vein thrombosis for many reasons. So let's keep it and we can exclude it once we do imaging, okay? Autoimmune hepatitis? Seems less likely. This patient doesn't have any history of other autoimmune diseases and less likely, less likely. And the presentation was just kind of acute, and he has multiple risk factors for liver disease. Autoimmune hepatitis less likely. But if you still want to keep it and investigate, you can investigate for autoimmune hepatitis. Alpha-1 antitrypsin deficiency. The manifestation could be at a young age, right? So, right? And pulmonary manifestations. Of course, this patient has shortness of breath and all that, but this is more of acute than a chronic problem. So alpha-1 antitrypsin deficiency, you can check, you can investigate, but this is also less likely. It looks like less likely. I'm going to remove it. Help me, guys. Acute liver failure, medication overdose with acetaminophen, keep or remove?
Remove.
Remove because there is no history. The patient has denied such history. Ovarian tumor?
He's a male patient.
He's a male. That is the reason why I said I would kill you, because but I didn't tell you the sex at that time, but now it's completely out. What about pregnancy? What about
Remove.
pregnancy? አምረኞች እኮ ናቸው. Nephrotic syndrome.
Keep.
Keep. Hepatosplenomegaly. Long list. Yeah, long list. Hepatosplenomegaly.
We have to still keep it. We don't have physical
Yeah,
examination.
physical examination is not done. It may be contributing to his increase in abdominal. Disseminated TB, interstitial TB.
Keep.
Keep it.
But why do you want to keep it?
Until you do an
Because we-
investigation, maybe.
No, why until you do physical examination? Can you exclude based on history? Or what should you have asked as part of the HPI? You didn't ask anything related to TB. So what are the information you should ask the patient?
Chronic cough or contact with the non-TB patient
Yeah,
or chronic
exactly.
cougher.
Excellent. History of cough, which is chronic. History of recent contact with a patient who has been diagnosed with tuberculosis, or history of treatment for tuberculosis in the past. Okay. So all this information is missing in this particular patient, so we can kick it out. Patient never had any exposure to a patient who has been actively diagnosed with tuberculosis. Okay, so that kicks it out. You don't have to wait until you investigate. Congestive heart failure, we talked about it, is still a possibility. Cardiomyopathy is still a possibility. Constrictive pericarditis, pulmonary, they are still a possibility. Right-sided heart failure is still a possibility. If you want to challenge me, you can challenge me. If you want to kick them out, come up with a suggestion and challenge me, we'll kick them out if you convince me. Okay?
I have a
Hypoalbuminemia.
question.
Yes, go ahead, please.
For constructive pericarditis, would this patient would have been presenting for such a long period of time?
Yes, I mean, like the presentation is going to be, the patient told you my abdominal girth was increasing gradually over the past year, but it all of a sudden became large in the past 2 weeks and a half. So the problem has been going on for some time. And the patient was complaining of shortness of breath. The patient has leg edema. So constrictive pericarditis is still a differential diagnosis, even though we are considering CLD to the most part. So still a possibility. So you can talk about causes. Constrictive pericarditis secondary to what? The commonest cause in Ethiopia is TB. What else? Radiation, right? So did you ask about radiation history? Chest radiation ማለት ነው. Patient with lymphoma, patient with breast cancer, they receive mediastinal radiotherapy, and that results in constrictive pericarditis. So those information are lacking. No history of treatment to TB, no recent contact with a TB person, with a TB patient, no history of chest radiation, no history of cardiac surgery. Because like or mediastinal surgery, that's also one reason why these patients may develop constrictive pericarditis. So in that case, constrictive pericarditis will be out, okay? Will be out. All these informations are missing. So less likely that this patient has constrictive pericarditis will be out. Cor pulmonale is still a possibility. Due to COPD, ማለት ነው. Right-sided heart failure is still a possibility. Hypoalbuminemia. Is it a possible? Yeah, we said nephrotic syndrome is still possible. Liver failure, it looks like he has liver failure. Malnutrition, he hasn't been eating well, so still a possibility. We'll keep it. Protein losing enteropathies, most of the time they may have associated diarrhea and all that. So that could be less likely. So protein losing enteropathies, will kick it out. And poor oral intake is still a possibility. Spontaneous bacterial peritonitis, we never know. Still a possibility, right? What about hepatic encephalopathy?
It's still possible.
It's still possible. He's confused. Alcoholic intoxication versus withdrawal. Remove them because yeah, based on history, we kick them out. Medication related. A patient doesn't have any history of recent medications. He takes only metformin and amlodipine. Medication related amlodipine. Shall I kick it out or remove it or keep it?
Like you've mentioned earlier, we could have considered hypothyroidism in this patient, but it's not just the patient doesn't only have leg swelling, he also has ascites. So
yes,
I guess kicking it out.
What about medication related? Medication, not medical comorbidities. So he takes amlodipine. Can amlodipine intake explain both leg edema and ascites or abdominal girth increase? We don't know whether this is ascites or not, by the way, mind you guys. So at this stage, we don't know whether the increase in abdominal girth is due to ascites or something else. It could be a mass lesion as well, malignancy. It could be like, ascites. It could be hepatomegaly, splenomegaly. We don't know whether this patient has ascites or not. We are just thinking in terms of differential diagnosis. So medication related, less likely. If it is like, ascites, amlodipine doesn't really cause ascites. It can explain leg edema. So if you want to talk about the leg edema, we can still keep amlodipine. ግልጽ ነው? So this is how much we can go at this stage. The list is still long, so that's why we need a physical examination. So tell me the type of investigations you want to do and what you expect. Tell me the type of physical examinations you want to do and what you expect. Be systematic, okay?
On general appearance,
Excellent.
the patient might be have an altered consciousness. He might not be awake or responsive. In addition, we've been mentioning he has also shortness of breath, so he might be in cardiorespiratory distress. So I think that's all in general appearance.
Excellent. ትንሽ ጨምሩላት ቤተልሔም ላይ
He can be also jaundice.
On the general appearance, we can
Jaundice on the
Yes,
general appearance.
jaundice. You may notice jaundice as well, right? Yellowish discoloration of the skin or yellowish discoloration of the eyes can be noticed on general appearance. So this particular patient actually has ectatic sclera, yellowish skin, He is kind of agitated. He's restless in bed, kind of fighting around. And he was kind of in a mild cardiorespiratory distress. He was breathing a little bit fast. So this is a general appearance. Exactly. That's what you should, that's what you expect in this patient. Good. You got it right. Okay, next. What do you want to do next? What do you examine next?
Vital signs.
Vital signs. Okay, what will happen to the vital signs? What do you expect in the vital signs? Because like, you know,
He
if
is a
a patient,
non-hyper.
yeah, go.
He is a non-hypertensive patient, so the BP is
Yeah, but
important.
no, but the BP is important, but remember this patient is taking treatment. Plus, patients in this, yeah, go ahead. So blood pressure could be uncontrolled or controlled. It depends, right? If it is adequately treated, it will be controlled. If it is not adequately treated, he may have hypertension. Very good. But his blood pressure was okay. His blood pressure was 100/60. So the treatment is working ማለት ነው. Or there could be another explanation. We will elaborate later, okay? Remind me later on what will happen to the blood pressure in such patients eventually as the disease progresses is something else. But like, you know, at least for now, he's on treatment, amlodipine 10 milligram, his BP is controlled fine. Okay. What else do you expect in this patient on the vitals?
The patient
ስለምትፈሩ
may
ነው.
feel weak.
Yeah, tachypneic, right? We talked about shortness of breath. So you expect the respiratory rate to be high. So respiratory rate is 24 per minute. Okay.
And also saturation.
Saturate,
Oxygen
what do you
saturation.
expect? What do you expect in the saturation?
Desaturate literature.
He may desaturate. So yes, of course, his saturation is 90% on room air, and the saturation drops further when the patient is sitting upright like this. It drops to 88%. So you have to, what does it mean? What does it mean? What do you call this? Desaturation. Huh?
Platypnea.
Another terminology. Or platypnea,
Orthodoxia.
orthodoxia, excellent, orthodoxia. So when he stands up or when he's sitting down, his saturation drops, orthodoxia. And platypnea is the patient's subjective complaint. So when I get up, he told you actually, right? When I sit up, I feel more winded, so more shortness of breath when the patient is sitting down. So in what situations do you expect this kind of problem? Orthodoxia and the platypnea.
In patient with hepatopulmonary syndrome.
Excellent. So in our differential diagnosis, we got one hepatopulmonary syndrome. So you have the history and you have the physical examination finding to support to consider hepatopulmonary syndrome. You got it? Okay, good. Very good. Beautiful. Okay, go ahead. Now those are the vital signs. One important vital sign is missing. You didn't ask about it. Actually, subjectively, I told you about it, but you have to objectively assess it as well. What is that?
Temperature.
Temperature. Temperature is normal. He didn't have fever. Why is it important in this particular patient?
Spontaneous bacterial peritonitis.
Excellent. So he is high risk to develop SBP or other infections for that matter. And, you know, ruling out infection is very important. And sometimes hepatic failure due to alcoholic hepatitis, acute alcoholic hepatitis can also present with fever. Okay, that's also another differential diagnosis for fever. So acute alcoholic hepatitis can be our differential diagnosis in this case, actually, by the way, in our differential diagnosis, alcoholic hepatitis. Did we include that? No. Alcoholic liver disease, alcoholic hepatitis. So patients with alcoholic hepatitis, they may present to you with fever. So that's very important. So that's all about vitals. So you see these things I told you. Then what is the next investigation? Physical examination. Vitals ብሎ ማን ነው የሚመጣው guys? After the vital signs, which system or part of the body do you examine?
HNT.
HNT. So what do you look in the HNT?
The yellowish discoloration.
Oh yeah, the
Yellowish
pulse rate. The
discoloration.
pulse rate is very important. We forgot about pulse rate in the physical examination, and the pulse rate was normal actually. So his pulse was only 82 per minute. Okay, that's also very important. Thank you so much, Yabsara, for reminding us. Okay, what did you say? HNT. So what things do you see in the HNT?
Yellowish discoloration of the eyes.
Yes, he has yellowish discoloration of the eyes. What else?
The conjunctiva.
Yes, he has pale conjunctiva. Why do you think this patient has pale conjunctiva? What are the reasons? What are the potential explanations for anemia in this kind of patients?
Anemia due to chronic disease.
Anemia due to inflammation, due to chronic disease. If he has cirrhosis, long-standing, yes. What else? What else?
Due to hemoconcentration, maybe.
Yeah, if the patient is dehydrated, hemoconcentration, that gives you actually elevated hemoglobin. It doesn't cause anemia.
No, due to build-up fluid build-up, maybe.
Due to what? አልተሰማኝም ናትናኤል you are breaking up.
Fluid build-up ካረገ
Yeah, less likely. There are more relevant causes. Hemodilution ማለት ነው. Hemoconcentration ሳይሆን hemodilution ማለት ነው. Then actually this group of patients, they do have their circulatory volume actually is really reduced because third spacing ስላለ ማለት ነው. Okay.
If the patient has splenomegaly.
Yes, if a patient has portal hypertension with splenomegaly, splenic sequestration, excellent. Or hypersplenism. What else?
Decrease the protein production important for iron transfer.
Not really.
If we're considering portal
Patient can
hypertension.
also have folate deficiency.
Folate deficiency, malnutrition, right? Folate deficiency, iron deficiency. Okay. What else?
Esophageal varices. We did not see it in this patient, however.
Yes, chronic GI blood loss. Yes, excellent. Cheers. Cheers.
Decreased intake.
Cheers.
Alcohol causes anemia.
Alcohol intoxication, right? Direct toxicity to the bone marrow. So alcohol. So this patient has a remarkable alcohol history. So chronic alcohol use by itself can result in anemia. So there are many reasons why this patient can be anemic. So you have to really rule out the presence or absence of anemia. Excellent. Very good. So, okay. So he has pallor. He has ectatic sclera. What else do you want to check as part of HMT? ታያችኋል እዚህ?
Bleeding gums.
Parotid gland
enlargement.
Parotid gland enlargement. Yes, especially those patients with alcohol history and all that, they may have parotid gland enlargement. What else?
We're considering Wilson's disease in this patient, so if I'm not mistaken, the Kaiser-Fleischer rings or something like that.
Yeah, so that needs eye examination, right? So you cannot identify that on physical examination. I don't think you can identify that on physical examination, right? I don't think so. But you are right. As part of the eye exam, if you are capable of doing that, you may see those rings. Yes. What else? Lymphogland. Oh, kaza HNT. This much is enough. The other, where is the other site you can check for anemia and jaundice? Actually, the best place to check for both of them. Eye,
The palm.
skin. Palm subjective, and then it may be very difficult for you to tell, especially like, በጣም በእጃቸው የጉልበት ስራ የሚሰሩ ሰዎች ሃይፐር ኬራቲናይዝ ስለሚያደርጉ ፔል ሊመስሉሽ ይችላሉ። ሶ they may confuse you. ዳርክ ስኪንድ ስትሆኚ ሊከብድ ይችላል። ኔል ቤድ ነው ሌላው፣ ስፔሻሊ ፎር አኒሚያ ቼክ ለማድረግ ኔል ቤድ ኢዝ የያዘር እንትን ካፒላሪ ሪፊል ካን ሄልፕ ዩ። ለጆንዲስም ለአኒሚያም ግን በጣም ሪሊያብል ሳይት አለ። የት ነው?
On the tongue. The frenulum of the
which
tongue.
which part of the tongue? The underside
frenulum.
or the upper side? Ventral or
frenulum, the
dorsal?
under. The
Ventral,
ventral.
right? ይሄ ማለት ነው። እንትናችሁን ምላሳችሁን ወደ ላይ ገልብጣችኋት የስረኛው ከስር ማለት ነው። የታችኛው the ventral aspect of your tongue can tell you for you can check for pallor as well as for jaundice there. Okay, so these are some of the things you can do, and you have to exclude whether this patient is dehydrated or not. So you have to examine the buccal mucosa and buccal mucosa dryness and all that. Check ማድረግ ይኖርብናል ማለት ነው. Very good. So next step is lymphoglandular system, right? What do you check in the lymphoglandular system?
Gynecomastia.
Gynecomastia, yes, gynecomastia. It's one of the peripheral stigmata of chronic liver disease or cirrhosis. So gynecomastia, very good. Very good. Okay, then next step. ቶሎ በሉ ጊዜ ለመቆጠብ።
Cardiovascular system.
Cardiovascular system. Lung ይቀድማል፣ cardiovascular ይቀድማል, by the way. So let's confusing me. Chest comes first, right? Respiratory system or chest. We say chest examination actually. We don't say respiratory system because the respiratory system encompasses many things up to the bronchioles and the alveoli, right? So you cannot examine the entire respiratory system. So we report it as a chest examination. So on chest examination, what do you do? What do you anticipate? What do you expect in chest examination?
The patient can have signs of respiratory distress and pleural effusion.
Pleural effusion is a possibility. Yes, exactly. This patient has decreased air entry over the posterior basal lung fields, right greater than the left. And he has also relative dullness in the bases bilaterally, right greater than the left. Otherwise, air entry is good, no wheezing, no rails, no crackles or crepitations. And trachea is centrally located. Okay, next. Next.
On the cardiovascular system.
So based on the information I gave you, what do you want? What do you understand? Relative dullness, right greater than the left, with decreased air entry at the bases, right greater than the left. So what's your interpretation?
The patient might have hepatic hydrotropes.
Yeah, most probably there is fluid, right? So it looks like there is fluid in the lung. Why does the patient have fluid? One potential explanation is hydrothorax related to ascites, right? How does ascites contribute to pleural effusion?
There might be diffusion via the diaphragm.
What do you mean by diffusion? Diffusion means, movement of fluid within a membrane, right? Permeable membrane, no? Diffusion, terminology አስተካክል።
እሺ ብዙ ማይግሬት ያደርጋል በጋፖቹ within the diaphragm ያሉት ሆሎች።
There are some holes, right? There are some holes where, like, the ascitic fluid can enter into the thoracic cavity. So hydrothorax is possible. And most of the time, which side is more involved, right or left?
The right.
Right.
The right. That's the reason why I said the decreased air entry and dullness is right is greater than the left. You know, I'm giving you an hint. The case is telling you what's happening. Okay. Very good. So the next step is cardiovascular system. What do you expect in cardiovascular system? Or at least what are the things you check for? ቀጥሉ።
For
አይዟችሁ
any signs
ጎበዞች።
of for any signs of pulmonary hypertension.
ዋት ዱ ዩ ሚን እኮ ንገሪኛ። እንደዚህ እንደዚህ እጠብቃለሁ፣ እንደዚህ ካለ እንደዚህ እንደዚህ ፊዚካል ፋይንዲኬሽን እጠብቃለሁ፣ እንደዚህ እንደዚህ ካለ በይኛ። ቀጥታ ማለት ነው።
Palpable P2 and P2 accentuation.
There is no P2 accentuation. P2 is not palpable. የማታወሩ ልጆች ሚዩት አድርጉ። ስታወሩ ብቻ ክፈቱ። እሺ። አረ ወንዶቹ ግን እየተበለጣችሁ ነው በእውነት እንዲህ ነችና። አረ ተበለጣችሁ።
Checking for the apical pulse, apical impulse. We are considering
apical impulse is like, you know, in the normal position, it's on the fifth intercostal space along the left mid-clavicular line. It's not displaced.
And how about the chest? Is it an active or
what? Precordium bay. አይዞሽ precordium.
Precordium.
The precordium is not active. It's silent precordium.
How about the multiple? Okay, never mind. Yes, it's silent. Sorry.
ሲስተማቲክ እኮ ብትሆኑ እናንተ ሲስተማቲክ አልሆንም ብላችሁ እምቢ አላችሁ እንጂ ካርዲዮቫስኩላር ሲስተም ስትባሉ ሲስተማቲክ አሁን ከፐልስ ነው የሚጀምረው። ካራክተራይዜሽን ኦፍ ፐልስ፣ ፐሪፌራል ፐልስስ እዚህ አሁን ለምሳሌ ሬዲያል ትላላችሁ፣ ካሮቲድ ምናምን ማለት ትችላለ ከፈለጋችሁ፣ ፊሞራል ፋንሲ ለመሆን ከፈለጋችሁ። ከዛ በኋላ ከፐልስ በኋላ ደግሞ ፕሪኮርዲያል ኤግዛሚኔሽን ጋር መታችሁ ወይም እሱን ከማድረጋችሁ በፊት ጄቪፒን ኤግዛምን ማድረግ፣ ጄቪፒ ሬዝድ ነው አይደለም፣ ፕሮሚነንት ኔክ ቬንስ አሉ የሉም እሷን ማየት። እሱን ስትጨርሱ ፕሪኮርዲየም ላይ መምጣት፣ ፕሪኮርዲየም ላይ ቅድም የጠየቅሽኝን ነገሮች መጠየቅ፣ የሚታይ ፐልሴሽንስ አሉ ወይ፣ አክቲቭ ፕሪኮርዲየም ነው ወይ የለም፣ ሂቭ አለ ወይ የለም፣ ምንም አይነት ሂቭ የለም አልኩኝ። ፓልፐብል ትሪል አለ ወይ ምናምን ትኛለሽ፣ የለም እላለሁ፣ የለውም ፔሸንቱ። ከዛ በኋላ የት ነው ፒኤምአዩ የት ነው? አይ ቶልድ ዩ ኦልሬዲ ፊፍዝ ኢንተርኮስታል ስፔስ ሚድ ክላቪኩላር ላይን ነው አልኩኝ። ዘን ኦስከልቴሽን ይመጣል። ፒቱም የለም ብያለው፣ ፒቱ አክሰንቹዌሽን የለም ብያለው። ኤስ1 ኤንድ ኤስ2 ዌል ሄርድ ኢን ኦል ዘ ቫልቩላር ፕሌስስ እላቸዋለሁ። ዜ አር ኖት መፈልድ፣ ኖ ኤስ3 ኖ ኤስ4 ኖ መርመር ኦር ጋሎፕ። አለቀ። አያችሁ፣ እንደዚህ ነው መደረግ ያለበት። ይሄን ፈቃደ ስላሴ እንዴት አጠናው? ከድሮ ጀምሮ እየተቀጠቀጥኩ በእናንተ ደረጃ ጀምሮ እንደዚህ አይደለም እየተባልን እየተወገርን ነው መስመር የያዝ ነው። ከዛው ልርሳ ብለውም አረሰውም አውቶማቲካሊ ከጭንቅላቴ ይፈልቃል ማለት ነው። አት ዘ ቲፕ ኦፍ ማይ ፊንገርስ ይሆናል። ስለዚህ እናንተም ሲስተማቲክ ሁኑ። አንዴ ፐልስ፣ አንዴ ጄቪፒ፣ አንዴ ኢዴማ፣ አንዴ ፕሪኮርዲየም፣ አንዴ ላንግ፣ አንዴ ሌግ ምናምን እያላችሁ አይሆንም። ዩ አር ዲስኦርጋናይዝድ ዩ ዶንት ዱ ፊዚካል ኤግዛሚኔሽን ዛት ዌይ። ምክንያቱም ጄቪፒ ቼክ አድርገህ ከእንደገና ፐልስ ቼክ አድርገህ መልሰ ፕሪኮርዲየም፣ ሰውየው ከተኛ በኋላ ደግሞ መልሰ ለሌላ እንደዚህ። ኖ ኢትስ ኖት ሲስተማቲክ፣ ኢትስ ኖት ኦርጋናይዝድ ኤንድ ዩ አር ኖት ጎይንግ ቱ ቢ ኤፊሽንት። ሶ ቢ ሲስተማቲክ። አይ ጌቭ ዩ አን ኤግዛምፕል ዊዝ ካርዲዮቫስኩላር ሲስተም። ሶ ትራይ ቱ ቢ ሲስተማቲክ ኦን አብዶሚናል ኤግዛሚኔሽን። ኦኬ። ስለዚህ ኖ ፐርቲነንት ፖዚቲቭ ፋይንዲንግ ኦን ኤግዛሚኔሽን ኦፍ ዲ ካርዲዮቫስኩላር ሲስተም። ኖ ፖዚቲቭ ፋይንዲንግስ፣ ኤቭሪቲንግ ኢዝ ኔጌቲቭ except he has bilateral lower extremity edema. Okay, he has bilateral lower extremity edema. ግልጽ ነው?
Yes.
Good. What other system do you want to check next?
The abdomen.
Abdominal examination. Don't say GIT, okay? We don't say respiratory system. We don't say gastrointestinal system. There is no way we can examine the entire GIT. There is no way we can examine the entire respiratory tract. So we say precordial examination. We don't say cardiovascular examination. Of course, we say cardiovascular system because pulses are included. and JVP and every other thing is included. But in GIT, you just say abdominal examination. So abdominal examination, okay, what do you expect? What are the possible findings and what are the things you do?
On inspection, see for the symmetry of the distension.
Yes, it is symmetrically distended abdomen.
Are there any flank fullness?
The flanks are full.
Any dilated veins? Visible dilated?
Yes, there are dilated veins, especially below the umbilicus.
Is
How is the
umbilicus
umbilical?
everted or inverted?
Huh?
Is umbilicus everted or inverted?
It's a little bit inverted.
Is there any bulging?
There is, it's just a diffuse swelling.
Are the hernia sites free?
Yes, they are free.
Is the abdomen moving with respiration?
It moves with the respiration, yes.
Any shifting dullness or fluid?
Yes, there is fluid trail with shifting dullness. Do you know how to do shifting dullness and fluid trails? Who can tell me how to do shifting dullness or fluid trail?
For shifting dullness, we'll start from the middle and we go to the lateral side and we will stop where there will be dullness.
What do you mean we go? You walk in the patient's belly or what? ሆዱ ላይ ቆመሽ ነው
No,
የምትራመጂበት?
percussing. I will percuss.
You start percussing over the umbilicus and you go lateral. That's how you describe, okay? You
Yes.
go on percussing, and then what happens?
Then when I find a dull area,
Mhm.
I will fix my finger there and make the
How
patient.
do you fix it? With a hammer and nail, or with what?
No,
What do you mean by fixing?
I will put my finger on the dull
You
area.
keep you keep your finger there, okay? You stay there, okay?
Yes.
Okay.
And turn the patient.
What do you mean turning the patient?
Excuse me?
What do you mean by turning the patient? Upside down?
No, turning him on the side, on his side.
So you tell the patient to turn his face to the other side, right? To the lateral, to the opposite side. So if you are coming to the right, you ask the patient to be in the left lateral ማለት ነው። ወደ ቀኝ እየመጣች ከሆነ በቀኝ ጎንህ ተኛልኝ ትይዋለሽ ማለት ነው። ዘን ዋት እጅሽንም እዛ ቦታው ላይ እንዳለ ማለት ነው። ሳታንቀሳቀሺ ፔሸንቱ እንዲህ ይጋደማል። ኦኬ ዘን ዋት
And then percuss on the same position.
Yes, you keep it there. ፊንገርሽ እዛው ላይ ነው፣ አልተንቀሳቀሰም። ፔሸንቱ ብቻ ፖዚሽኑን ቀይሯል። You still keep your finger there. Then you continue percussing. You wait a couple of seconds. Why do you need to wait for a couple of seconds after the patient changes position?
For the fluid to shift fully.
Yeah, the fluid has to shift, right? So just a couple of seconds and the fluid automatically goes to the dependent area. So then you start percussing again and what happens?
There will be a tympanic note.
Tympanic region. So that is what is meant by shifting dullness. Whatever has been tympanic becomes dull, whatever tympanic becomes dull, and whatever dull becomes tympanic. That's what is meant by shifting dullness. So you can also do it the other way around. So you can start, percussing እና ከደልነሱም ከዚህ ከጥግም ተነስተሽ ወደ ሴንተር መተሽ ከሴንተር መተሽ ወደ ጥግም ሄደሽ አይዘር ወይ መስራት ይቻላል ማለት ነው። And the commonest way and the way I do it is exactly the same thing you mentioned. I start from the center where it is tympanic. I go to the dull area. I ask the patient to change direction and then start percussing. And you have to do the same thing on the left side because, you know, ascites gives you typically bilateral flank fullness. እና ባይላተራል ፍላንክ ደልነስ። ስለዚህ ኢዘር ዌይ ብትሰሪ ታገኘዋለሽ። ኢዘር ዌይ ብትሰሪ ታገኘዋለሽ። If you have huge hepatomegaly, the hepatomegaly may be on your way in the right side, and it may be difficult to demonstrate for you shifting dullness. In that case, you know, you do it on the contralateral side, on the left side, ማለት ነው። And what about the fluid thrill? How do you check for fluid thrill?
For the fluid thrill, we will need an assistant.
Okay, you may or you may not need, necessarily you may not need. But, you know, people say, you know, you can use an assistant, yes. And what do you do?
Our assistant will have the hands at the center
Like this,
and
and
push
then push አድርጎ stabilize አድርጎ ቤሊውን ይዝልናል። Then what do we do?
We will put our one hand on the one side of the patient, and the other hand will try to make a wave by flicking.
Yes, ሆዱን ማለት ጣቴ እጄ ይታያል አይደል? እንደዚህ ሆዱን እንደዚህ በእናንተ ተቃራኒ ባለው ሳይድ በኩል ሆዱን እንደዚህ ደግፋችሁ ወደ እናንተ ዳይሬክሽን ትይዙና ከዛ ዘያዘር ፊንገር እንደዚህ ይመታል ማለት ነው። ታፕ ያደርጋል ቤሊውን በጣታችን ታፕ ስናደርግ what happens is we create vibration, waves of vibration. And then the vibration comes በኔ ሳይድ ነው የምመታው። በኔ ሳይድ ታፕ አደርጋለሁ። ዘያዘር ሳይድ በእጄ እንደዚህ አለ፣ እጄ ሆዱ ላይ አለ። when I tap it I create a vibration and the vibration comes and touches my fingers. And now we call it fluid thrill. Okay? ልክ አሁን እኮ በውሃ በባሊ ኖሮ ውሃውን እንትኑ ባሊውን በሆነ ብረት ነገር እንደዚህ ጓ ብታረጉት you see the waves going አይደል? to the other side you create a wave. እና shifting dullness ምንድነው fluid thrill የሚባለው እሱ ነው። You know how to demonstrate that one. Okay? You should know how to do it. Okay, what else do you want to do? So he has fluid thrill and shifting dullness, okay? Visible veins አሉት። Visible peristalsis መኖር አለመኖሩን ማወቅ አለባችሁ, especially if you are considering a possibility of intestinal obstruction with an acute abdominal distension. Then you know sometimes patients may have visible peristalsis if there is an active mechanical obstruction of the bowel ማለት ነው. Okay, what else do you expect? Inspection አረጋችሁ palpation እያረጋችሁ. Okay, palpation ቀጥይ.
We look for organomegaly.
Organomegaly. So now he has hugely dilated, distended abdomen አለው እና significant ascites አለው. So how do you appreciate organomegaly? It's going to be difficult, right? So
Yes, it's going to be difficult. We'll try to ballot.
Ballot. So you check for ballot presence or absence of a ballotable organ. How do you check for balloting? Ballotable organ. You see how I am moving my head? እያያችሁኝ ነው?
Yes.
እንደዚህ እያረጋችሁ organomegaly ካለ when you do this, if there is hepatomegaly, you touch the liver ማለት ነው. When you push the belly like this, push, you feel the liver. በስፕሊን በኩል ሄዳችሁ እንዲህ ስታረጉ you feel the spleen. This guy has ballotable spleen and ballotable liver አለው. So hepatosplenomegaly አለው ማለት ነው. On top of the ascites, on the top of fluid accumulation. What else do you want to check for?
Is there any tenderness on palpation?
There is no tenderness, no direct or rebound tenderness. What else? Huh?
We try to milk the veins if there are any dilated veins.
Compress. You compress the veins, and then what happens to them?
We see the direction of flow, and
The
that will
direction.
indicate whether it's hypertension or something else, such as IVC complex.
So what do you expect in portal hypertension? Let's say there are dilated veins below the umbilicus. You try to milk them. So what do you expect in portal hypertension? If it is portal hypertension, actually, this test is not really specific. It's not specific. It's not sensitive.
The head would feel away from the umbilicus.
Yeah, so ወደ ታች drain ያደርጋል. Most of the time, if it drains, if it feels downstream, then most probably it's related to portal hypertension, right? So the periumbilical veins normally drain into the iliofemoral venous group. So if it is due to portal hypertension, the direction of flow of the veins is downstream, downwards. And if it is related to, portal hypertension, congestive heart failure, and all that, the direction of flow might be reversed upwards. Okay, good. All right. What else do you want to check? Auscultation. On auscultation. ቶሎ በሉ guys.
Bowel sound. We check for bowel sound.
Bowel sounds. You check for bowel sounds. Yes, you check for bowel sounds as well. And it was very difficult to appreciate the bowel sounds because of the ascites. What else do you want to check?
Bruit over the liver and the spleen.
A bruit, or what do you mean by a bruit? Yes, the presence or absence of a murmur actually. So it has a name. I forgot the name. Around the umbilicus, you can put your stethoscope and you try to find out if there is a bruit or a murmur. Okay. A venous hum. It's actually a venous hum ነው የሚባለው ምናምን የሚል ማለት ነው። All right. Sounds good. Sounds good. And what other system do you want to examine? And don't forget digital rectal examination. And if a patient has GI bleeding, you may notice the presence of melena or dark stool. You may also notice prominent varicosities, because one of the areas where varicosities can happen is down in the perianal region, right? The postosystemic circulation communicate የሚያደርግበት አካባቢ is around the lower part of rectum anorectal region አካባቢም ስላለ you may see prominent veins around there, dilated tortuous የሆኑ ማለት ነው። Okay, sounds good. And what other system do you want to examine? ቶሎ በሉ for the interest of time. Let's not kill too much time, okay? Straightforward ጥያቄ ስለሆነ ቶሎ መልሱ please. ኢንተጉመንታሪ ሲስተም እኮ ንገሩኝ። ኢንተጉመንታሪ በሉና አታቁሙ። እኔ ተናገሩ እስክል ኢንተጉመንታሪ ሲስተም ይሄ በሉ ነው የምላችሁ።
Excoriation marked in the integumentary system and yellowish discoloration for jaundice.
Yes, yellowish discoloration of the signs of excoriations. What else? And somebody texted it in the
Palmar erythema.
Palmar erythema, excellent. What other peripheral stigmata do you anticipate in the integumentary system? Palmar erythema. What?
Spider nevi.
Yes, spider angiomas. Yes, spider angiomas or spider tail angiectasias ይሏቸዋል. Yes, they are also peripheral stigmata. Okay. What else can happen in the palm?
Thenar and hypothenar atrophy.
Yes, thenar and hypothenar atrophies. Duptrinous contracture. Excellent. This can be seen. Excellent. What other system do you want to examine? The extremities, right? So what do you anticipate in the extremities?
Edema.
He has pedal, pretibial edema. He has sacral edema as well. And he has foot edema as well. Pedal, ankle, and pretibial edema. Yeah. Very good. And he has also sacral edema. And what is the last system you want to examine?
The central nervous system.
Central nervous system. So what do you anticipate in this patient?
Altered level of consciousness.
Altered level of consciousness, so you can calculate Glasgow coma scale, okay?
They might have a flapping tremor.
They may have flapping tremor, okay? Or asterexis. He does have asterexis. Asterexis allow. Do you know how to do asterexis? How to demonstrate asterexis or flapping tremor? I was demonstrating in our last session, but like, you can tell me now. How do you demonstrate?
We ask the patient to outstretch their hands as if saying a stop sign.
Outstretch and what?
Extend their palms in the stop sign one is no.
A stop sign. So what has happened here in my wrist? ምንድን ነው happen ያደረገው? Extension or flexion?
Extension.
አይደለም. What kind of flexion is happening? I'm flexing. What kind of flexion is this?
Dorsiflexion.
Dorsiflexion. Excellent. Dorsiflexion ስታረጉ ነው stop sign የሚሆነው። ቆም የምትሉት እኮ dorsiflex ስታረጉ ነው። Dorsiflexion of the hands with fanning out of fingers like a stop sign and both fingers, and then this is how they manage. It may not be symmetric. It may not be symmetric and rhythmic like this. So it flaps like this, flaps. Asymmetric flapping, okay? So asterexis could be seen. And he has asterexis. His Glasgow coma scale is 15, but he is kind of confused and restless. No sensory, gross sensory or motor deficit, okay? Sounds good. And he's not oriented. He's confused. He's oriented only to person. So I'm not going to read this out because, it's straightforward and already we have talked about it. So the findings I have told you already, okay? I have told you the findings. So what do you see here? Testicular atrophy ትክክል ነው። Testicular atrophy should also be done as part of the genitourinary system ላይ you have to examine his testicles. That's very important. Thank you so much. So testicular atrophy, you have to examine the testicles. Very good. So what is this? What do you see here?
Gynecomastia.
Gynecomastia. Which one? This one or this one? One for this, two for this. Which one is the gynecomastia? One or two? This is one, this is two.
One.
One. You can see enlarged breast, right? Look at this in the set tonal gynecomastia. It's one of the peripheral stigmatas of CLD or chronic liver disease, okay? Or cirrhosis. Something important we have forgotten. What is that? What is this?
Clubbing.
Clubbing is also very important because patients with cirrhosis may present to you with clubbing. And now clubbing define ለማድረግ you see this angle here at the nail bed that has to be less than 160 degree. 100 obtuse angle ነው less than 160 መሆን አለበት. If it becomes more than that, then there is clubbing. You can see, there is distorted angle at the nail bed. So this angle here is kind of distorted. You can see swollen. It's swollen. It's kind of ትሙክ የሚል ነገር ነው። እንዲህ ይዛችሁ ጫን ስትሉት ጣቱን ይዛችሁ እንዲህ ኔል ቤዱን ቼክ ስታደርጉት እንደ ስፖንጅ የሳሳ ነገር ነው እና ደግሞ ያው የወፈረም ነው እንደምታዩት ዲስቶርትድ ነው as you can see here. So there is clubbing of fingers. ድራምስቲክ ይመስላል አይደል? የድራምስቲክ ይመስላል አፒራንሱ በጣም ወርዝ እየሆነ ሲመጣ ማለት ነው።
በፍቃድ ነጭ ወደን እኮ ነው ሁሌ የምጠቀመው ነጭ ነው።
እና ያው ክለቢንግ ያው associated conditions differential diagnosis አቤት አስፋወሰን ልቡ እንትኑ ኔትወርኩኛ ጋር ነው ልቡ እዛ ወሬ ላይ ነው። Clubbing, heart lung diseases, GI diseases, liver diseases, Crohn's colitis, cirrhosis, Graves disease, malignancy, all these are differential diagnoses. COPD, whatever, corpulmonale, ሁሉ lung disease, heart diseases, clubbing ያመጣሉ። Like I told you, this angle here, the black angle, less than 165 degree መሆን አለበት። ክለቢንግ የምንለው እንደ ቀዩ በሚሆንበት ጊዜ ነው። ዘ ሬድ ላይን ሪፕሬዘንትስ and the angle becomes greater than 165 ዲግሪ ማለት ነው። እና በደንብ ይሄ ፓርት አሁን እዚህ ፓርት ላይ ኮምፕረስ ታደርጉት ቬሪ ስፖንጅ እና ይሄ ፓርቱ እንደ ድራምስቲክ ብጥ እያለ ይመጣሉ ጣጣዎቹ ማለት ነው። as typical clubbing ስለ ፒቲንግ ኢዴማ ያው you know the places the sites where we check for edema edema grading I think ሴሽን 2 ላይ የሰጠዋችሁ ኖት አለ አሁንም ኢንክሉድ አድርጌዋለሁ you can refer that one so this is pre-tibial edema it's pitting edema it's pits and it stays there በደንብ ነው ዲፕረስድ የሆነው this is maybe plus 4 edema and ሌላም ስላይድ አለኝ ሳይቶቹን ማወቅ አለባችሁ ኢዴማ ዲሞንስትሬሽን አንደኛው ፔዳል የምንለው ነው it's over the dorsum of the foot you can see a very clear depression ነው እና እንደዚህ ተደርጎ ነው ደግሞ በደንብ for about 5 seconds ጫን ብላችሁ መያዝ አለባችሁ against the bony prominences ነው pre-tibial against the tibia ነው sacrum against the sacrum ነው እንደምታዩት you keep your patient in a sitting position ankle edema most of the time you press against the medial malleolus always press against the bony prominence press for about 5 seconds or 10 seconds and then see the reaction ማለት ነው what happens okay so this patient has all the edemas already ተናግሬያለሁ this is how you do it classification you can read about it at your own pace degrees of clubbing you can also read about it okay people grade it it doesn't matter as far as you identify that the patient has clubbing that's enough and what is the name for this one what is the name
Caput medusa.
Caput medusa yeah so this is a medusae medusa is like she is found in Greek mythology and this lady has her hair was changed into snakes as you see so the head of the medusa ማለት ነው caput means head ማለት ነው okay so you have to understand what the term means caput means the head of medusa so it looks like the head of the medusa because this is her head right so it looks like it አይደል አይመስልም and you can also see distended veins even above the umbilicus it's more prominent below the umbilicus as you see it resembles the caput medusa okay our patient had that one and the other thing we mentioned was pulmonary erythema you should know that pulmonary erythema most of the time involves the thenar imminence and the hypothenar imminence and there is a spared area you see this there is a spare in the palm in between the two so pulmonary erythema is another sign of advanced liver disease by the way all these things caput medusa clubbing and ይሄ ምንድነው gynecomastia presence of pulmonary erythema these are like signs of advanced liver disease ናቸው patientaችን has all of them unfortunately and our patient didn't have dupiternous contracture but for the sake of our discussion I have brought it you can see there is a dupiternous cord as well as nodule formation you can see the cord so there will be flexion deformity and that happens because of fibroblast proliferation no due to fibroblast proliferation no they lay down a lot of collagen and that results in dupiternous contracture like this differential diagnosis are multiple even like normally those individuals who are engaged in daily laborers በእጃቸው ብዙ ነገር የሚቀጠቅጡ ብዙ ሸክም የሚያነሱ ሰዎች through time they may develop a dupiternous kind of contracture develop ሊያደርጉ ይችላሉ okay so differential diagnosis ማወቅ ያስፈልጋል it may not necessarily mean pathology in all patients and our patient had spider angioma so spider it looks like a spider that's why they called it the spider angioma so what you see in the center which is more radar is like an arteriole it's a dilated arteriole and then there are branching capillaries and you can see like this spider telangiectasias they are commonly seen in the face in the trunk upper extremities okay so you can see them you see they are like there is the arteriole which is dilated which is sitting in the center there are branches of capillaries going outwards okay and there are multiple in the trunk as you can see here okay and face the trunk upper extremity is commonly affected they are like peripheral stigmatas nacho it's present I think it's present in our patient I guess if I remember so let's narrow our differential diagnosis now we have physical examination ስላለን ሊስቱን ቶሎ ቶሎ ብለን እንትን እንበለው ናሮው ዳውን እናርገው። አሁን ተዘጋጁ። ኦኬ ቶሎ ቶሎ ለመመለስ ፕሊስ ቶሎ ቶሎ። ከዛ በኋላ ማኔጅመንቱ ላይ ትንሽ ጊዜ መስጠት እንድንችል ኖ ኖ ኖ ኖ ኖ ኖ ኖ ኖ ኖ ኖ ኖ ኖ Are you guys happy so far?
Yes.
Okay. አልሰለቻችሁም አይደል?
አይ
ቢሰለቸንስ ምን ምርጫ አለ? አንተን ከምናስከፋ ዋጥ አድርገናል አልሰለቸንም እንላለን እንጂ ሌላ ምን ምርጫ አለን? አይዟችሁ አትሰላችሁ። ኦኬ አሁን ቶሎ ቶሎ ናሮ ዳውን እናት። ኦኬ አልኮሆሊክ ሊቨር ዲዚዝ ይቆይ አይቆይ? ይሄ ጥሩ ዳያግኖሲስ ነው አይደል? ዲኮምፐንሴትድ ሲኤልዲ ሲሮሲስ ዊዝ አሳይተስ አሁን ፐርፌክት ነው። አልኮሆሊክ ሊቨር ዲዚዝ ይቆያል። አልኮሆሊክ ሄፓታይቲስ ሌስ ላይክሊ ነው አይደለ? ምክንያቱም ቴንደር ሄፓቶሜጋሊ የለንም፣ ፊቨር የለንም። ሞስት ኦፍ ዘ ታይም ሄፓቲክ ምንድነው አልኮሆሊክ ሄፓታይቲስ ሞስት ኦፍ ዘ ታይም they tend to have fever, they will have tender hepatomegaly and it tends to be somehow acute, so less likely no alcoholic hepatitis less likely. But remember, decompensated cirrhosis versus alcoholic hepatitis, they are always a challenge to differentiate between the two. Okay, it's very difficult to differentiate between the two. So we can still keep it, we can also kick it out. Non-alcoholic fatty liver disease, this guy is not obese. Even though I didn't tell you BMI was normal, it's like 24.4. So non-alcoholic fatty liver disease, ያው አልትራሳውንድ እስክንሰራ ድረስ እንቆይ ካላችሁም ማቆየት እንችላለን። ክሮኒክ ቫይራል ሄፓታይቲስ ሲ ቫይረስ ስለነበረ ይቆያል። ካርዲያክ ሲሮሲስ
there is nothing suggesting of cardiac disease.
Excellent. Wilson's disease
latest stay ምን
yeah
እስካሁን
we can check later. Hepatocellular carcinoma still possible. Burkieri syndrome
still it's a possibility.
Possible.
Still possible. Okay, let's keep it. Nephrotic syndrome
it is still possible.
ያ አሰች እንደው ቲፒካል ነገር የለንም የምናስወጣበት። ሄፓቶስፕሌኖሜጋሊ ያ patient has hepatosplenomegaly ግን as part of the manifestation of the same disease ስለሆነ እናውጣው ይሄንን as part of the manifestation of the first differential decompensated CLD cirrhosis with ascites with portal hypertension with portal hypertension በሚለው ሄፓቶስፕሌኖሜጋሊ የዛ ማኒፌስቴሽን ስለሆነ እናስወጣዋለን። CHF
less likely.
cardiomyopathy
less likely as well.
or pulmonary
Less likely.
right-sided heart failure
Less likely.
hypoalbuminemia still possible.
Possible.
SBP
unlikely.
Less likely.
less likely. Hepatic encephalopathy
Possible.
possible.
medication related amyloidopathy
Less likely.
hepatopulmonary syndrome
possible.
ያ እንደውም ያለ ነው የሚመስለው እኮ ፕላቲፕን ያለው ኦርቶዶክስ ያለው እኮ ፔሸንቱ ኤቪደንስ አለን በደንብ። እሺ እንቀጥላ እንግዲህ እዚህ ጋር ደርሰናል። አሁን ኢንቨስቲጌሽን ንገሩኝ ቶሎ ቶሎ። አሁን ይኸውላችሁ ሲቢሲ ብላችሁ ዝም እንዳትሉ። ሲቢሲ ላይ ይሄን ያለው ቢኤምፒ ወይም ሲኤምፒ የሚል ይሄን ያለው አልትራሳውንድ የሚል ሰው ይሄን ያለው ለማለት ነው እንጂ ሲቢሲ ምናምን ለማለት ከሆነ ዝም በሉ። እሺ ቀጥሉ።
On CBC we'll check the hemoglobin count because we are considering anemia and also the platelet count because with liver disease, there is a chance of it being low. WBC still, why not? I don't think it's relevant.
Excellent. So he has thrombosis. I mean, he has pancytopenia actually. Anemia low. What kind of anemia do you anticipate in this patient? The chronicity sound, or most likely chronic anemia of chronic disease, anemia of chronic anemia. Again, what kind malate? Macrocytic or normocytic malate?
Microcytic.
If it is iron deficiency, yes. Deficiency, yes. But I don't think so. What is prominent in this patient of all the things?
Alcohol causes macrocytic anemia.
Yeah, so most likely either macrocytic anemia or normocytic anemia if you are thinking of anemia of chronic disease. So this patient actually has elevated MCV. Mean corpuscular volume was 102. So he has macrocytic anemia, okay? Macrocytic anemia low, platelet count was 70 something thousand. So thrombocytopenia low and leukopenia low. WBC count was also low. So one of the things which helps you to differentiate between alcoholic hepatitis and decompensated liver failure is the presence of leukocytosis. Because alcoholic hepatitis presents with fever, abdominal pain, and tender hepatomegaly, and presents with leukocytosis as well. Okay, so leukocytosis is missing, liver failure, fever is missing, and hepatic tenderness is missing. So that makes alcoholic hepatitis less likely. Okay, that helps us in the differential diagnosis as well. Okay, CBC, we are done with CBC. Go ahead, another test.
Maybe on serum chemistry to order albumin.
Yes, albumin. His albumin is only 1.9, so he is hypoalbuminemia. Okay.
Liver function test.
Yeah, ንገረኛ, liver function test. What are the
enzyme.
components and what do you expect? Okay.
The liver enzyme, bilirubin, albumin.
Tell me
and
what
the
you
coagulation
expect.
factor.
Liver enzymes, what do you expect?
Elevated level of liver enzyme.
Liver enzymes, okay. Mildly elevated liver enzymes. They won't be above 500 most of the time, okay? Okay.
Elevated level of bilirubin.
Elevated level of bilirubin. He is jaundiced, so you anticipate elevated bilirubin, okay?
And decreased level of coagulation factor.
Coagulation factors will be low. So how does it manifest?
Bleeding.
What kind of test do you do to assess for coagulation disturbance?
PT or PTT?
Yeah, you do PT actually. So you do PT and INR. So you check for prothrombin time and also INR. You can also check for activated partial thromboplastin time, PTT, check ማድረግ ትችላለህ. Okay, excellent. So with AST and ALT, what kind of pattern ratio do you anticipate if it is related to alcohol? It looks like this is mainly related to alcohol. So what kind of distribution do you anticipate in terms of their elevation?
AST is more elevated.
Yes, AST is more elevated, and typically in their ratio, AST to ALT ratio, how much would it be? More than how much would it be? 10, more than 2, more than 1? So this is a very typical board question ነው by the USML line, but I'm commonly asked question, no? AST to ALT ratio would be greater than 2, by the way, if it is related to alcohol, significant alcohol. Very good. And even a patient with decompensated liver failure, AST will be more elevated than the ALT, more than 1 ይሆናል ማለት ነው ሬሾቸው። አልኮሆል ከሆነ ደግሞ remarkably due to alcohol ከሆነ more than 2 ይሆናል። In some patients earlier in the process of the illness, ALT might be slightly elevated than the ALT, so the AST to ALT ratio would be less than 1 ማለት ነው. Early, but as you go along and disease worsens, AST to ALT ratio would be more than 1 for sure. And if it is mainly due to alcohol, it will be greater than 2. The ratio would be greater than 2. Okay, very good. And what else do you check in terms of other than AST, ALT? What else do you check? You check for obstructive GGT, yeah, GGT. GGT is all very typical, very specific for liver pathologies, right? ምክንያቱም AST and ALT can be elevated due to muscle pathologies, placenta-related pathologies in females, bone-related pathologies. So if you want to make sure whether these enzymes are elevated due to liver pathology, take for GGT. GGT will also be elevated. Gamma glutamyl transpeptidase ነው መሰለኝ GGT አይደል? Gamma glutamyl transpeptidase መሰለኝ GGT. So it will be elevated in a patient with liver disease. GGT will be elevated, and alkaline phosphatase has to be also checked. It will also be elevated. Okay, that's very important. Very good. Very good. Good, good, good. Okay, what other tests do you want to do? Part of CMP. No, CMP ውስጥ still አለ እኮ ብዙ ኮምፖነንት እኮ ነው ያለው CMP. Liver function test 1
renal function test including
renal
electrolytes.
function test. What do you expect in this patient? What can happen to the renal function test in this patient?
The urine and creatinine can increase.
Can increase. Actually, his creatinine is elevated in this patient. So he fulfills criteria for AKI. He has acute kidney injury. So I'm going to add acute kidney injury here as a differential diagnosis. He has AKI or like, multiple diagnoses ሊኖረው ይችላል አንድ patient. Hepatic encephalopathy ያለው. It looks like he has hepatopulmonary syndrome. It looks like he has AKI. He fulfills the criteria. ምክንያቱም ቤዝላይን ክሪያቲኒን ከ0.3 ሚሊግራም ፐር ዴሲሊትር በላይ ከጨመረ በ0.3 ከጨመረ ከቤዝላይኑ that is a criteria for AKI. Or if it increases creatinine is elevated by more than 50% from the baseline, that fulfills the criteria. That patient has that criteria. Okay, he has AKI. Okay, very good. What else do you want to check for this patient? What other test? Okay, blood test ከጨረሳችሁ ወደ ሌላ ሂዱ። ስታክ አታርጉ እዛ ላይ።
Urine analysis.
Excellent. Urine analysis. What do you anticipate and what do you check for?
Urine protein, since nephrotic syndrome is in our differential.
Excellent, excellent. Yes, differential diagnosis is nephrotic syndrome, so you have to check for proteinuria. He doesn't have proteinuria. ሌላውስ ምንድነው የምታደርገው? Simple proteinuria check ታደርጋለሽ. If there is proteinuria, then you have to quantify it, right? So what kind of tests do you do to quantify the amount of protein loss?
24-hour
Yes.
protein.
Excellent, excellent. You can check, you can collect 24 hours urine and then measure the amount of urine protein. What else can you do with just at the spot to determine the degree of proteinuria?
Dipstick. Protein to creatinine ratio.
Excellent. Urine protein to creatinine ratio. So if that is how much should it be to diagnose as a nephrotic syndrome?
Greater than 3.
Yeah, greater than 3, greater than 3.5 should be fulfilled to diagnose it as nephrotic syndrome. Okay, that's very important. Very good. Protein to creatinine ratio. Excellent. What other investigations do you want to do? Urine ሰራችሁ, blood ሰራችሁ. Don't get stuck, guys. Move on. Move on.
Imaging, ultrasound was mentioned.
Ultrasound. So what do you anticipate during ultrasound in this patient?
Nodules on the liver,
Yes.
liver enlargement,
Yes.
and also
Hepatonegative.
fluid.
Yes, fluid. You confirm presence of ascites, presence of nodularities. You can also check for presence or absence of hepatocellular carcinoma, something suspicious for HCC on ultrasound. And you can also check elastography, hepatic elastography. You can measure how stiff the liver is. Okay. Very good. Very good. What else can you do? You guys were suspecting SBP, so I mean, it looks less likely. What do you want to do?
Ascitic fluid
Diagnostic
study.
parasynthesis.
Excellent. Diagnostic parasynthesis, you can do both diagnostic as well as therapeutic. This patient is in distress. This patient is in respiratory distress. It can also serve as a therapeutic parasynthesis. So analyze እናደርጋለን. As part of ascitic analysis, what are the components you should do? You should check.
serum acidic albumin gradient.
የስ ስለዚህ እሱን ለማድረግ ሴረም አልቡሚን ኦልሬዲ ቼክ አድርገሃል። ስለዚህ አሁንም አሳይትሱ ላይ አልቡሚን ሌቭል ቼክ ታደርጋለህ ማለት ነው። ጉድ ሳግ ይባላል አይደለ? ለሴረም ቱ አሳይተስ አልቡሚን ግራዲየንት ለማድረግ ቦዝ ሴረም አልቡሚን ሌቭል አዝ ዌል አዝ አሳይቲክ አልቡሚን ሌቭል ቼክ መደረግ አለበት። ዋት ኤልስ?
culture.
ቢ ሲስተማቲክ። አልቡሚን ካወራ ዜር ኢዝ ሰምቲንግ ኤልስ ዊች ሹድ ቢ ቼክድ ዊች ጎዝ አሎንግ ዊዝ አልቡሚን። ሜሞራይዝ ስታደርጉ እንደዛ ብታደርጉ አትረሱም። ያለ እንደዚህ እዛ አትሸምደዱ። ከአልቡሚን ጋር አብሮ የሚሄድ ቼክ ይደረግ።
total protein count
ቴንክ ዩ ሶ ማች። ቶታል ፕሮቲን። ስለዚህ ቶታል ሴረም ፕሮቲን፣ ቶታል አልቡሚን፣ ቶታል ፕሮቲን ሌቭል ዊዝን አሳይትስ ሃዝ ቱ ቢ ቼክድ። ኦኬ ጎ አሄድ ናው።
cell count with differential
Excellent. Cell count with differential diagnosis. Yes, with yeah. What else? Culture ብላችኋል. You can do culture. Gram stain, you can do gram stain. Even though the yield is very low, you can check ascitic culture, ascitic gram stain, and whatever.
Cytology.
You can do cytology because one of the differential diagnosis could be
Carcinoma.
yeah, peritoneal carcinomatosis or malignancy. So you can do also like, you know, cytology. Beautiful, beautiful. What other investigation do you want to do? Is there anything else?
Gene
To
expert.
exclude? Huh?
Gene expert.
Yeah, gene expert TB ምናምን ለማድረግ less likely ነው እንጂ you can do gene expert to exclude tuberculosis. What else? Shortness of breath አለው አላለ? Pleural effusion አለው አላላችሁም? How do you confirm that? And how do you quantify that?
Chest X-ray.
Simple chest X-ray, yes. Echocardiography can be done because, you know, that excludes completely pulmonary hypertension ካለ ምን ከሌለ ይነግራቸዋል። ስለዚህ you have to do echocardiography. Now you are talking about ሄፓቶፕሉመናሪ ሲንድሮም። ስለዚህ ሄፓቶፕሉመናሪ ሲንድሮም ሰስፔክት ካደረግን ደግሞ ኤኮ with agitated saline injection can help you can confirm intra pulmonary right to left shunting ያሳየናል ማለት ነው። ስለዚህ ኤኮ can be done. Echo with agitated saline to diagnose hepatopulmonary syndrome. ስለዚህ you can do that as well. Do you get it? ኦኬ ሌትስ ሲ እንግዲህ ፔሸንቱ ምን እንዳለው ይሄው ፕሌትሌት ምንም አልደግመውም ኦልሬዲ። ሌላው የረሳችሁት ኤሌክትሮላይት ነው። ሶ ሂስ ሶዲየም ኢዝ 128 is that what you expect? Hyponatremia is a possibility, right? So it's a possibility. And creatinine was 2, baseline it was 0.9, so it's a significant bump in the creatinine. And random blood sugar has to be checked. This is a patient with diabetes. So the confusion could be due to what? Hypoglycemia, right? So even though like, you know, the patient wouldn't be really confused for one day, ያን ያህል ሌት ከሆነን ብዙ complication develop ያደርጋል if the confusion was due to hypoglycemia. So that makes it, the presentation makes it less likely, but random blood sugar or fasting blood sugar has to be checked. And urinalysis, PT and INR were both prolonged. INR was 2.5. And the other thing you forgot, and you shouldn't forget, is chronic hepatitis panel, because his hepatitis C virus antibody is positive, but his hepatitis C virus viral load was undetectable. So that goes with his history, right? So he has past infection, but he's cured. And hepatitis B surface antigen is negative. Hepatitis B surface antibody is negative. What does it mean? What does it mean?
It means the patient has not been infected with hepatitis B in previous.
And what else does it mean? Yes, no active infection. What else?
He has also never been infected.
Is the patient immune against hepatitis B?
He is not.
He is not. So he is not immune. So his hepatitis B surface antigen antibody is negative, means this patient was never vaccinated or he never had past infection. Sometimes, like, you know, some people might become immune after infection. So He was not. So this guy needs vaccination. Right upper quadrant ultrasound elastography ብለናል paracentesis LDH መጨመር አለባችሁ chest x-ray EKG echo ቦዛን remarkable let's narrow our የመከረኛ differential diagnosisአችንን እናጥብብ እንግዲህ
There was a question in the chat box.
Okay, what is that?
Do we have to write every complications as a differential? So can't AKI be explained by the hepatorenal syndrome? Was asked.
የተለያየ አፕሮች አለ አሁን እዚህ ሀገር ምንድነው ሊስት ኦፍ ዲፈረንሻል ሊስት ኦፍ ዳያግኖሲስ ነው የምትዘረዝሪው any case you can explain AKI ብለሽ then it's because of prerenal azotemia ነው prerenal azotemia የሆነበት ምክንያት ኤክስፕሌን ታደርጋለሽ አንደኛ effective circulatory volume is low ምክንያቱም ሰውየው remarkable የሆነ edema third space shift አለው ሁለተኛ ነገር ደግሞ patients with decompensated heart failure portal hypertension they may have vasodilatation of the splanchnic circulation በዛ ምክንያት reduced renal blood flow አለና prerenal azotemia የምንለው ለዛ ነው and you explain that okay prerenal azotemia due to reduced renal blood flow as a result of splanchnic vasodilatation so you explain your thought process እዚህ ሀገር እንደዛ አርገሽ ነው ዲፈረንሻል ዳያግኖሲሶችን ቁጭ አርገሽ ማኔጅመንቱንም በእያንዳንዱ ስር ስለምታስቀምጪ ማለት ነው or you can say like you know a patient with decompensated liver failure as a complication he has AKI he has hepatopulmonary syndrome he has hepatorenal syndrome ብለሽ ማስቀመጥም ትችያለሽ that's also possible I think የኛ ሀገር ሲስተም እንደዛ ነው እኔ አሁን ሞር እንግዲህ አሜሪካዊ ያደረጉኝ ስለሆነ የዚህ ሀገሩን ካልቸር you know both ways are possible you can put it as a comorbidity as a comorbid problem ወይም እንደ ኤክስፕሌን በሚደረግበት ኤክስፕሌን ማድረግ ይቻላል both ways ያስኬዳል ግልጽ ነው ተረድታችሁኛል አባባሌ
Yes.
Okay so let's narrow down main problem ያው decompensated CLD መሆኑ ነው ምንም ጥያቄ የለውም that is what is bringing hepatorenaluንም hepatopulmonary syndromeንም የሚያመጣ ማለት ነው so alcoholic liver disease ይዘናል viral hepatitis ይዘናል Wilson's disease ምንድነው ቼክ የምታደርጉት ለዊልሰንስ ዲዚዝ
serum copper level
ያ ኮፐር ሌቨል እሱ ኖርማል አብኖርማል አይደለም ሄሞክሮማቶሲስ ላይ what do you check for
transferring
transferring
what do you do አንደኛው ፌሪቲን ሌቨል ነው አይደል አንደኛው ቶታል አይረን ባይንዲንግ ካፓሲቲ ነው TIBC የምንለው ነው ሌላኛው ደግሞ ኤሊቬትድ ፌሪቲን ሌቨል ነው የሚኖረው ምክንያቱም አይረን ስቶራቸው በጣም ሃይ ስለሆነ the ferritin will be significantly elevated እና TIBC would be also low የቶታል አይረን ባይንዲንግ ካፓሲቲ ሎ ነው የሚሆነው ኤክሰሲቭ አይረን ስላለ ማለት ነው already those binding places are already filled up so TIBC would be low and ferritin will be elevated and that way you diagnose hemochromatosis that is absent in our patient hepatocellular carcinoma is kicked out because there was no evidence of hepatic mass okay screening ያስፈልገዋል obviously because this patient is high risk to develop hepatocellular carcinoma in the future ይሄንንም አሁን አይ ቲንክ አንድ ፔጅ ላይ ማድረግ እንችላለን ስለጠበቡ አሁን በርካሪ ሲንድሮም do you want to keep በርካሪ do you want to keep በርካሪ አላችሁ
አለ ነው
do you want to keep በርካሪ syndrome
unless it is ruled out with ultrasound You can keep it.
Ultrasound has ruled out it. Yellam, ምንም የለም. Ultrasound ላይ የለም. There was no evidence of portal, hepatic vein thrombosis, so it's out. Nephrotic syndrome?
Remove it.
Remove it? Yeah, nephrotic syndrome is out. Normal ነው.
Urine
Protein
admissions ላይ ምንም አልነበረም።
የለም አልነበረም። ትክክል ነው። Patient definitely has hypoalbuminemia ያለው ግን that's part of this problem, it's because of the cirrhosis and decompensated liver function ነው. Nephrotic syndrome is out. Yes, liver failure. Yes, there is liver failure. There is some component of malnutrition, but poor intake የጀመረው the past 2 weeks ነው እንጂ ከዛ በፊት ሰውየው ደህና ስለነበረ malnutrition is out and his BMI was 24 point something, so malnutrition is less likely. Again, the hypoalbuminemia is present due to liver failure. That's part of the main issue here. Hepatic encephalopathy, he has it, right? Patient has hepatopulmonary syndrome. Yes, the patient has it, fulfills the criteria. Patient has AKI, and it looks like patient has a hepatorenal syndrome. We'll talk about it, what it means. So his creatinine is significantly elevated, like, more than 0.3, that fulfills the criteria for hepatorenal syndrome. In a patient with decompensated cirrhosis ማለት ነው. ግልጽ ነው? So now the list is short. Now basically the main problem is this one. Decompensated CLD or cirrhosis, and the cirrhosis is most likely related to both alcoholic liver disease and chronic hepatitis infection. Hepatitis B is out, actually. We screened it already. So patient had past hepatitis C virus infection. Even though he is cured, already the damage is done. The fibrosis has already happened. ግልጽ ነው? ግልጽ ነው ወይ ወንድም እህቶቼ? እዛኑልኝ እንጂ አታስለፍልፉኝ።
Yes, it is.
እሺ ኤነርጂ እየተዳከመ ነው። 2 hours አወራን እና አሁን ቶሎ ቶሎ ምልስ ስታረጉ ላይፋችን ይቀላል። ጨርሰናል። አሁን ማኔጅመንት ላይ ነን። ኦልሞስት በቃ we have got the final diagnosis አይደለ? We got the final diagnosis. Pretty much this is the diagnosis. Decompensated CLD cirrhosis, and the main pathophysiology is due to alcoholic liver disease and chronic hepatitis C virus infection. And these are manifestations or complications of this CLD, be it hepatic encephalopathy, hepatopulmonary, hepatorenal syndrome, AKI. These are part of the AKI. Actually, I can kick out AKI because that's included in the diagnosis of hepatorenal syndrome. And this patient is dealing with all these things at this point. Okay, good. So summary, that is the summary. I kind of summarized it. ማኔጅመንት ፕሪንሲፕልስ አሁን እንግዲህ በቃ ይሄ ፔሸንት አላችሁ። እስቲ 1-2 ደቂቃ ዝም ብለን አረፍ እንበል እንዳይሰለቻችሁ። በቃ 1 ደቂቃ ተንፍሱ ውስጥ የሆነ ነገር በሉ። አር ዩ ሃፒ? ወዚት ቆንጆ ነበረ ዲስከሽኑ? የሆነ ነገር በሉ ውስጥ።
Yes, it was very nice. አሪፍ ነበር እስካሁን የነበረው ዲስከሽናችን in my opinion.
Yes, it is very helpful.
And Brooke has joined us.
Which line, Professor? Duke.
እስቲ በሉ እያልኩኝ ነው እኮ አታስለፍልፉኝ እያልኩኝ ነው እኮ። አፌን ዘግቼ ነው እንደለካ። ከየት እንደሆናችሁ እስቲ ጻፉልኝ። ከየት ሜዲካል ስኩል ናችሁ? እስቲ ሊያው ከየት ነው የተሳተፋችሁ? Justice for psych. ጎንደር ሳንቴ። እሺ በጣም አሪፍ። ሳንቴ ብላክ ላይን ጻፉ ጻፉ ጻፉ። ብላክ ላይን ብላክ ላይን ጎንደር ብላክ ላይን። ዛሬ ጥቁር አንበሳ ተጠረቃቅማቸዋል ከያላችሁበት። ብላክ ላይን ኮሪያ እህቶቻችን ወንድሞቻችን አባረራችኋቸው እንዴ? ብሩክ ያኔ ባለፈው ሳምንት ብዙ እነሱ ነበሩ ኮሪያ። ማን ያስከፋብኝ? ጎበዝ ልጆች ደግሞ በዛ ላይ ጥቁር አንበሳዎች አባራችኋቸዋል ማለት ነው እነዛን የመሰሉ ልጆች። አረ ጻፉ 18 ልጆች ከየት ከየት ናችሁ? የት ከየት ከየት እንደሆናችሁ ትልወቀው ብዬ እኮ ነው። ቴክስት አድርጎ የተናገሩ። አረ በስመ አብ። ሳንቴ ኤዶም። እሺ ሳንቴዎችን ደግሞ በሚቀጥለው እንዳታባርሯቸው ብሩክ ነግሬሃለሁ። ይኸው ኮሪያ ባለፈው ቢሳተፉ ዛሬ አባራቸዋቸዋል። ኦኬ እንቀጥል። ከየት ናችሁም? ዝም። ስማችሁስ ምንድነው? ዝም። ምንድነው ዓላማችሁ? ዝም። ትምህርቱ ጥሩ ነበር ወይ? ዝም። በስመ አብ ወወልድ ወመንፈስ ቅዱስ።
There is one person from Jimatu.
ጅማው ቴንክ ዩ መሰረት አይቼዋለሁ። መጽሐፉም ዝም ቄሱም ዝም ሆናችኋል። እሺ እንግዲህ መቼስ እጸልይላችኋለሁ የሚያስለፈልፍ መንፈስ እንዲልክባችሁ። ለነገሩ እኮ ለፍላፊዎች እኮ እንደ ፖለቲከኛ አይደል እንደምታወሩት ኤምሳ ምናምን ስትሰበሰቡ ቆይ ቆይ እስቲ አጀንዳው ምናምን እሺ በቃ ቶሎ ቶሎ ብለን ትንሽ ስላይዶች ናቸው የቀሩን። ሲምፕሊፋይ አድርገን እንትን እንበል። ያው the principle of management እንግዲህ አሁን it depends on the etiology. Alcoholic hepatitis እና decompensated cirrhosis, like I told you, most of the time it's a little bit difficult. Differentiating between the two is often difficult. Alcoholic hepatitis, fever, jaundice, tender hepatomegaly, and leukocytosis are most of the time present. And that might help you, to find out if you are dealing with acute alcoholic hepatitis. Severity of alcoholic hepatitis, there are different ways to determine severity. Madre discrimination function የሚባል አለ. This is a formula. You can simply calculate using this formula, or you can use MD calc የሚባል app አለ. I don't know. Try it if it works for you guys. MD calc የሚል. This is it. MD calc. Do you see it? ባክግራውንድ መጠቀም ችግሩ ነው። MD calc. Do you see it? MD calc? ስለምትናገሩ እኮ እኔ እኮ ዝም ኢግኖር ላረጋችሁ ነው። እግዚአብሔርን እያበሳጫችሁ ነው። አሁንስ
Yes, it is visible.
MD ካልክ ይባላል። MD ካልክ CALC ማለት ነው። ካልክ MD ካልክ እሱን አፕ እስቲ አውርዱት። MD በካፒታል ሌተር ሲም በካፒታል ከዛ ALC MD ካልክ በጣም አሪፍ ነው። ያ በቃ በጣም ጥሩ በቃ if it works እሱን ዳውንሎድ አድርጉና እነዚህ የሚባሉትን ነገሮች ሁሉ በቀላሉ ካልኩሌት ማድረግ ትችላላችሁ። ሶ ማድሬ ዲስክሪሚኔሽን ፋንክሽን የሚባል አለ። እንደ ሞዴል ሜልድ ስኮር ደግሞ የሚባል አለ። ሞዴል ፎር ኢንድ ስቴጅ ሊቨር ዲዚዝ ማለት ነው። that can also be used to assess severity of alcoholic hepatitis እና ይሄ ማድሬ ስኮር ከ32 በላይ ከሆነ ሜልድ ስኮር ሞር ዛን 20 ከሆነ ሲቪር ስለሆነ or presence of hepatic encephalopathy like in our patient, you have to treat them with prednisolone, not with prednisone. What is the difference between prednisone and prednisolone? Why is prednisolone chosen? You have to know that.
Because prednisone needs hepatic activation.
Excellent. It's clear. Yeah, prednisone is actually cleared by the liver. That's why you don't want to give it. prednisolone doesn't require any hepatic metabolism ማለት ነው። ስለዚህ በሊቨር ሜታቦሊዝም ላይ ዲፔንደንት ስላልሆነ we prefer prednisolone. Okay, we prefer prednisolone. So if you are dealing with alcoholic hepatitis and if it is severe with MADRE score more than 32, mild more than 20, then treat them with prednisolone. Okay. Contraindications for steroid: acute infection, upper GI bleeding, AKI, concomitant liver disease with a hepatitis C, hepatitis V, or multi-organ failure are contraindications for steroid treatment. If no indication for steroid treatment or non-severe cases, just continue supportive care. That includes nutritional evaluation, thiamine replacement, alcohol treatment with goal of abstinence, and CWA protocol. If a patient was actively drinking, if the last drink was, for example, yesterday, this patient is high risk for withdrawal አይደል? እና withdrawal ውስጥ እንዳይገቡ CWA protocol የሚባል አለ። Clinical Institute withdrawal assessment ማለት ነው። We always put our patients with significant alcohol history on CWA protocol. And component to ምንድን ነው? You may give gabapentin, you may give clonidine to avoid withdrawal symptoms, but to help with the withdrawal symptoms. And sometimes you may also give them phenobarbital, and sometimes, and then depending on the score, you have to give them short-acting benzodiazepines ማለት ነው። diazepam ሊሆን ይችላል ወይም ativan ሊሆን ይችላል. So you can give them to avoid withdrawal symptoms and not withdrawal related seizure ምናምን develop እንዳያደርጉ ነው። So CWA protocol, but this patient doesn't really our patient doesn't really need to be on CWA protocol because the last alcohol he drank was about 2 weeks ago, so he's less likely to develop alcohol withdrawal at this point. Okay, so no need to put him on CWA protocol at this point. And response to steroids has to be reassessed after 7 days, and there is a score called the Lilly score. So MDCalc would help you to calculate Lilly score. And if Lilly score is less than 0.45, continue treatment for 28 days. If it is more than 0.5, that means these patients are not responding to steroid. And they are not responding, plus steroid by itself with hepatic failure makes them prone to infection, so stop it right away. Okay. Lilly score is based on initial bilirubin level, bilirubin at day 7, and the age of the patient, the albumin level, and creatinine and PT level. So these parameters are taken into consideration to calculate Lilly score. And all patients with advanced alcoholic liver disease should be referred to hepatology, okay? Whether they are abstaining or not, just refer them to hepatology for further evaluation and management and further consideration of hepatic transplantation, okay? Do you have any question with this? That is as far as hepatic alcoholic hepatitis is concerned, okay? That management. Acute on chronic liver disease, most likely our patient is suffering from acute on chronic liver disease. Common cause mortality in patients with CLD, precipitating factors like alcohol use. So he has recent alcohol use, so probably that precipitates. One of the precipitating factor is recent alcohol use in our patient. Viral hepatitis. So if a patient with CLD cirrhosis develops acute hepatitis B, acute hepatitis A, or acute hepatitis C virus infection, they will develop acute on chronic liver disease, okay? A drug-induced liver injury, like, if they consume any hepatotoxic medications like acetaminophen, recent surgery, ischemia, or infection can predispose patients like yes. Infection, good example of infection is spontaneous bacterial peritonitis, okay? Leads to decompensation. Organ failure can involve the brain, the kidney, respiratory tract, circulatory system, and coagulation function, okay? At least our patient has affection of kidney, the brain is affected, the kidney is affected, respiratory tract is affected in our patient. So management of ascites in general. So if this patient came without decompensation, yeah, I mean, the cirrhosis is decompensated. The moment the patient develops ascites, that means the cirrhosis is already decompensated. So management of patients with ascites due to decompensated cirrhosis, one of them is salt restriction. the amount of salt should be less than 2 grams within 24 hours. And you have to put them on diuretics, and the diuretics of preference is spironolactone and Lasix, and the proportion should be 100 to 40. You can start with spironolactone of 40 and furosemide of 40, and then you escalate. When you escalate, ያንን proportion ጠብቃችሁ ነው። Okay? ይሄንን አሁን ለምሳሌ 200 ብታረጉ ይሄንን 80 ታረጋላችሁ ማለት ነው። ይሄን 300 ስታረጉ ይሄኛውን 120 ታረጋላችሁ። ይሄንኛውን 400 ስታረጉ ይሄኛው 160 ይሆናል ማለት ነው። You escalate the dose depending on the patient's response and discontinue alcohol as much as possible. Alcohol has to stop. Any medication which will compromise renal perfusion like NSAIDs, beta blockers, ACE inhibitors, ARBs, if they are being taken, they should be discontinued automatically, okay? And you have to treat the underlying disease whenever it is possible. If it is infection, address that one. If it is any underlying other medical condition, you have to treat, and you have to titrate the dose of this spironolactone and furosemide depending on response. Read the rest of the statement. So paracentesis can be considered if ascites doesn't resolve with sodium restriction and diuretics. You have to give supplemental 25% albumin. Dose is here, especially if you are removing more than 5 liters right away at one go. You have to supplement with albumin, otherwise there will be significant circulatory compromise. Okay. Intermittent paracentesis can be considered for patients with long-standing ascites and symptomatic. And you can also consider TIPS. TIPS is transjugular intrahepatic portosystemic shunt ማለት ነው. That can be done in a patient with portal hypertension ማለት ነው. Especially those patients with refractory ascites and a low MELD score. MELD scoreaቸው low ሆኖ recurrent refractory ascites ያላቸውን you can put TIPS or transjugular intrahepatic portosystemic shunt ማለት ነው. Or portoazygous disconnection እንሰራ ነበር ኢትዮጵያ, that surgical intervention, but TIPS is much more better. A pleural effusion, the same management, continue diuretics, salt restriction. Sometimes if the patient has significant respiratory distress due to significant pleural effusion, you can consider thoracentesis. Okay. ሳግ ይቅርታ፣ ሳግ እንደዚህ ነው። serum to ascites albumin gradient ማለት ነው. If it is greater than 1.1, these are the differential diagnoses. If it is less than 1, most of the time, either TB ነው, pancreatitis ነው, carcinoma ነው, cirrhosis, nephrotic syndrome. These are the most important differentials. If it is less than greater than 1 ከሆነ ደግሞ these are the differential diagnoses. Okay. Brooke, I have seen your hand. I will give you the opportunity to ask. Go ahead, you can ask now.
There was a question in the chat.
Okay, what was the question?
Do we also have to add furosemide to spironolactone?
Yes. Furosemide, Lasix እኮ ነው. Lasix and furosemide plus spironolactone. 100 milligram of spironolactone plus furosemide. If it is like, decompensated at liver failure with significant ascites, yeah. Potassium supplementation አያስፈልግም። ለምን?
Because spironolactone is potassium sparing diuretic.
Potassium sparing ስለሆነ yes. We don't need it. Very good. Spontaneous bacterial peritonitis ፔሸንታችን የለውም፣ ግን ፕሪንሲፕሉን እንድታውቁት ብዬ ነው። Our patient didn't have spontaneous bacterial peritonitis, but if a patient has spontaneous bacterial peritonitis, the ascitic fluid should be tested for the following: aerobic and anaerobic culture, cell count and differential, gram stain, albumin, total protein, glucose, lactate dehydrogenase, amylase, bilirubin level. And normally what you should do is you have to aspirate enough amount of ascites using a 20 milliliter syringe of ascitic fluid and send it for analysis ማለት ነው, and do all these tests. So diagnosis, indications for primary prophylaxis of SPP. For example, our patient doesn't have spontaneous bacterial peritonitis. So we have to do primary prophylaxis ማድረግ አለብን. So in patients with cirrhosis and ascites, long-term antibiotics treatment with fluoroquinolones. And from the fluoroquinolones, what is preferred is norfloxacillin. You can also use Cipro. So if the ascitic fluid protein is less than 1.5, these are the indications, okay? If there is impaired renal function with creatinine of more than 1.2, BUN more than 25, serum sodium less than 130, and liver failure with bilirubin of more than 3, these are all the indications for primary prophylaxis of SPP. And our patient does fulfill all, probably most of the things. Most of the things fulfill ያደርጋል. So we have to initiate treatment with norfloxacillin or ciprofloxacillin as a primary prophylaxis against SPP. If a patient has already developed SPP, diagnostic criteria ምንድን ነው? Ascitic fluid neutrophil count ነው. Total cell count ሳይሆን neutrophil count has to be more than 250 per microliter or higher. Culture of a negative. Immediately, once you diagnose SPP, immediately you have to start treatment with third generation cephalosporins like ceftriaxone, especially if the infection is acquired, community acquired. And IV albumin has also to be given day 1 and day 3. Dose is this much, okay? And patients with kidney dysfunction or significant hepatic dysfunction with bilirubin more than 5, they are more likely to benefit from this treatment, from albumin. And albumin supplementation has a survival benefit as well, okay? Once you diagnose SPP. Our patient doesn't have SPP, so we don't have to do that. And once there is an SPP, indefinite secondary prophylaxis is indicated. The reason being, spontaneous bacterial peritonitis has a tendency to recur, so secondary prophylaxis is a must. You have to give norfloxacillin or ciprofloxacillin. Temporarily, you have to hold beta blocker if there is hypotension or AKI, and you have to immediately consider liver transplant and refer them to hepatology because SPP has a very high mortality, okay? So they are candidates for transplantation, so do timely referral if you have access. ኢትዮጵያ ውስጥ አይሰራም። ቴዎሬቲካል ነገሩን እንድታውቁት ነው። Hepatic encephalopathy ስላለው ፔሸንታችን we have to know how to manage patients with hepatic encephalopathy. So it's a brain dysfunction ranging from minimal abnormalities to frank coma now. Can be spontaneous or precipitated by other factors like infection, sedating medications, volume depletion, GI bleeding, constipation, and all that. If it heralds worsening liver functions, for sure, patients with severe disease should be treated in ICU. Consider intubation if diminishing consciousness or loss of airway protective mechanisms. Airway protective reflexes, a gag reflex ምኑ depressed ከሆነ, and if you think the patient cannot protect the airway, you have to consider intubation. Treat precipitating factors. If it is GI bleeding, address that. If a patient has portal hypertension with esophageal varices and active bleeding, you have to do, band ligation and all that. Infection, treat the infection, avoid sedating medications as much as possible. And initiate treatment with lactulose. Our patient had constipation. He didn't pass any bowel movement over the past 5 days. So we have to immediately start lactulose, and we have to plan for 3 to 4 bowel movements within 24 hours. And lactulose is a non-absorbable disaccharide now እንደምታውቁት. What it does is it just absorbs and shifts all these nitrogenous toxins into the GIT እና በዛ remove ያደርግልናል ከሲስተም. Rifaximin is also another non-absorbable antibiotic. So what it does is it just changes the GI flora እና እነዚህ urease positive የሆኑትን microorganisms banan urea producing urease holding microorganisms ይቀይርልናል ማለት ነው, so that we avoid formation of nitrogenous toxins. So it's much more tolerable than lactulose, but the only problem is it's not the first choice. The first choice is lactulose. Rifaximin is very expensive even in the US, so for that reason rifaximin may not be the first choice. And patients, once they recover, when you send them home, You send them home with lactulose, and they should titrate the dose of the lactulose based on the bowel movement. They should have 3 to 4 bowel movements within 24 hours. Okay, they need to have that one. ሄፓቶሬናል ሲንድሮም ፔሸንታችን ያለው ይመስላል። ታይፕ 1 እና ታይፕ 2 ተብሎ ፈርዘር ክላሲፋይ ይደረጋል። ኢትስ ዲው ቱ ሪዲዩስድ ሬናል ብለድ ፍሎ ዲው ቱ ሳይመልታኒየስ ዳይሌቴሽን ኦፍ ዘ ስፕላንክኒክ ቫስኩሌቸር ነው። ስለዚህ ሬናል ብለድ ፍሎ ኮምፕሮማይዝድ ይሆናል። ታይፕ 1 is a rise in serum creatinine at least 0.5 or above or 50% or greater from the baseline within 48 hours ማለት ነው። Urinalysis is bland most of the time. Normal kidney ultrasonography, exclusion of other causes of acute kidney injury, especially volume depletion. It's a diagnosis by exclusion ማለት ነው. And patients have low fractional excretion of sodium and they will have oliguria. Type 2 is somehow, a chronic gradual decline in renal function in a patient with refractory ascites, okay? So our patient seems to have like hepatorenal syndrome. So how do you manage it? Treatment of precipitating conditions, withdrawal of diuretics, and volume expansion with IV albumin. Okay, that's very important. You try to expand the circulatory volume by transfusing with IV albumin. Vasoconstrictors can be a treatment options to increase mean arterial pressure. ምክንያቱም mean arterial pressure ሲጨምር renal blood flow ስለሚጨምር ማለት ነው። So there are specific choices. Terlipressin የሚባል አለ. That is what is recommended by the American Gastroenterology Association. But if that is not available, then you can also give norepinephrine, okay, as a vasoconstrictor. So all patients with cirrhosis and acute kidney injury should be considered for urgent liver transplant evaluation. Patients whose kidney function does not improve with therapy may require hemodialysis while they are waiting for liver transplantation ማለት ነው። liver transplantation right away ስለማይገኝ ማለት ነው። ሄሞዳያሊሲስ ላይ ወይም ደግሞ continuous filtration ላይ ማድረግ እንገደዳለን if they develop hepatorenal syndrome with liver kidney failure. Hepatopulmonary function, we already talked about it. The mechanism is there are dilatation of, it's because of dilated intrapulmonary vessels in patients with portal hypertension and resulting in right to left shunting of blood and hypoxemia. The dilated vessels are located in the inferior aspects of the lung. የሳምባችን ታችኛው ክፍል ላይ ነው የሚኖሩት እነዚህ dilated veins ማለት ነው። እና that is the reason why when you sit up, the lower part of your lung is more perfused with blood. እና ስለዚህ more shunt happen ያደርጋል ቁጭ ስናደርግ ማለት ነው። more right to left shunt happen ባደረገ ቁጥር more dyspnea ይኖራል፣ more desaturation የሚኖረው። ቁጭ ሲሉ desaturation የሚያደርጉት፣ ቁጭ ሲሉ shortness of breath ወርዘን የሚያደርገው ለዛ ነው። Because blood tends to pool in the lower segments of the lung when the patient is sitting upright. You should know the mechanism. እዚህ ጋር orthodoxia and platypnea. So management too, the diagnosis should be suspected in patients with portal hypertension who have dyspnea and hypoxemia. Echo with agitated saline, I talked about it. Initially treated with supplemental oxygen. The only effective treatment you have to know is liver transplantation, okay? Liver transplantation. Portopulmonary hypertension is another differential diagnosis, especially if the patient has significant dyspnea. Less common than hepatopulmonary syndrome is a complication of advanced cirrhosis with high mortality rate. Echo demonstrate right ventricular systolic pressure greater than 50. So yeah, pulmonary evidence of pulmonary hypertension ይኖራል ማለት ነው በኤኮ ላይ. Right heart catheterization is needed to confirm the diagnosis. That is the best way you can diagnose pulmonary hypertension. Echo shows you some evidence, then right heart catheterization will give you a definitive diagnosis. Was formerly a contraindication for liver transplantation, but nowadays, if you treat them with vasoconstrictors and if the pulmonary artery pressure becomes less than 35 with vasodilator therapy, then they can still be a candidate for liver transplantation, okay? In the past, automatically, if a patient has portopulmonary hypertension, then it was a contraindication for liver transplantation again. If you give vasodilator treatment and if you can lower the pulmonary arterial pressure to less than 35, they can still be considered for liver transplantation. And prostacyclin analogs, phosphodiesterase inhibitors, like sildenafil, endothelial receptor antagonists can be used. Okay. And the other thing we didn't talk about is like, actually our patient didn't have GI bleeding, but if the patient had GI bleeding, most probably it's due to esophageal varices. So one of the investigations you should do, we didn't talk about it, was what?
Endoscopy.
Endoscopy, upper GI endoscopy መሰራት አለበት. In fact, any patient with cirrhosis, you have to do endoscopy to rule out the presence or absence of esophageal varices ማለት ነው። ascites ያለው patient ጠቅላላ endoscopy indicated ነው. So there are indications for treatment with beta blocker treatment, non-selective beta blocker የምንላቸው like propranolol, carvedilol, they can be used for prophylaxis of GI bleeding from esophageal varices. And እሱን ለማድረግ ኢንዲኬሽኖች አሉ like endoscopy ስትሰሩ if there is no sign of esophageal varices, you can repeat the endoscopy after 3 years. If you see small እንትኖች ካያችሁ varices ካያችሁ less than 0.5 millimeter size ያላቸውን ካያችሁ you can repeat after 2 years. But small less than 0.5 millimeter esophageal varices with surrounding erythema ካያችሁ እንደሱ አይነት ነገር ካያችሁ that's an indication for primary prophylaxis with beta blocker treatment ማለት ነው. And if the size is greater than 0.5 millimeter ከሆነ የቫሪሲያል ሳይዙ then you have to initiate treatment with beta blocker, propranolol most of the time. Or if a patient has hepatic encephalopathy ካላቸው decompensated የሆነ ነገር ካላቸው you should initiate treatment with beta blocker ማለት ነው. Or sometimes ደግሞ ምንድነው if a patient is not tolerant to beta blocker treatment, you have to do band ligation. You have to do band ligation. ግልጽ ነው?
Yes. Yes. It is.
Are you guys happy?
Yeah, we are
Yes.
very happy.
You better be. I mean, we discussed almost the entire GI ዛሬ ሄፓቶሎጂን እንደው ሙሉን ባይባልም አብዛኛውን ነገር ዛሬ ነካክተናል አይመስላችሁም?
እውነት ነው።
ትንሽ ውዳሴ ከንቱ አዝንቡ እንጂ አልፎ አልፎ ምንድን ነው? ጉሮሮ ደረቅ ታይም ፎር ሰም ኤክሰርሳይዝ ኦኬ።
እስከዛ ድረስ ግን ቻት ቦክስ ላይ ጥያቄ መጥቷል።
ምንድን ነው
አስፋው ሰናለቃ were you in dorm 39 ሜዲካል ስኩል የነበርክ?
አይደለሁም። ምን ነው እዛ ስሜ ተጽፏል? አልነበርኩም። ሀውልት ሰሩልኝ እ
ሃፒ ኒው ይር 2003 FSH የሚል አግኝቼ ነው።
ሪሊ ግድግዳው ላይ ነው። ፎቶ አንሳና ላክልኝ።
አይዲድ እሺ ልካለሁ።
ላክልኝ እስኪ this is interesting no 39 አልነበርኩም። መጀመሪያ 8 ቁጥር ነበርኩኝ። ፈርስት ፍሎር ላይ 8 ቁጥር ነበር። ከዛ የ8 ቁጥር ችግር ምንድነው? በዛ በጎማ ቁጠባ በኩል በመንገዱ በኩል ነውና ሌሊት መተኛትም አይቻልም። የጭነት መኪና ሲጮህባችሁ ነው የሚያድረው። በዛ ምክንያት እንደምንም በብዙ ተጋድሎ ከእንደገና ደግሞ አብረውኝ የነበሩ ሲኒየሮች ትንሽ አቢዩዚቭ ነበሩ። አንደኛው ዶርማችን ውስጥ እርግብ ያረባ ነበር እና እኔ ብዙ እዛ ዶርም ስለማልጠቀም ስለነበረ በቃ አልጋዬ ላይኛው ነበር። አልጋዬ የወፍ መከማቻ ሆኖ የእርግብ ለማዳ እርግቦች በቃ አስለቀቁኝ እርግቦቹ ማለት ይቻላል። እኔም ብዙ አላድርም ነበር። ከዛ 20 ቁጥር ገባሁ። 20 ቁጥር ነበርኩኝ። በኋላ ግን አይ ቲንክ ከሰከንድ ይር በኋላ ፎር ዘ ሬስት ኦፍ ዘ ሜዲካል ስኩል I was in dorm number 20. dorm number 20 ወደ ሜዳው በኩል ነበር። very peaceful. I love that dorm. 3 ነበርን። በጣም ዘና ብለን ነበር። የሆቴል አይነት ኑሮ ነበር የነበረ ለ3 እና 20 ነኝ 39 አልነበርኩም ማለት ነው። አዎ ማለት ሲኒየርህ ሲፈልግ ጅብን ቢያረባ ዝም ብለህ ነው የምታየው፣ መቃወም አትችልም እ ምንም ዝም ብለህ ማየት ነው። ለመግባት ራሱ እኮ እየተሳቀቅን ነበር የምንገባው መጀመሪያ አካባቢ ኢንተርን ምናምን ዶርም ውስጥ ካለ እስክትለምዳቸው ድረስ ሾከክ እያልክ ዶርም አይመስልም። የሆነ በቃ የሆነ የሌላ ሀገር እንዲህ ጥገኝነት የጠየቅ ሰው ነው የምትመስለው። በቃ ተንሿከ ነው የምትገባው። ይቅርታ እየጠየክ ነው የምትገባው። ሲኒየሮችን ይቅርታ ረበሽኳችሁ ምናምን። አሁን እናቴ እንኳን ሲኒየራችሁን አቴንዲንግ ታባርራላችሁ እናንተ። ጥያቄ ላመጣ ነው አሁን ይምጣ ጥያቄ።
አዎ
ጥያቄ ይምጣ ይቅር።
ይምጣ።
እሺ አይ ትንሽ ሰመራይዝማ እናድርግ ለጥያቄ። እስቲ ላክልኝ በእናትህ ግን 39 በእውነት እንደው ባለውለታዎቼ ናቸው። ስሜን እዛ ሃፒ ኒው ይር ነው ያሉት። የት አይነት
ሜቢ
ደጋ
ሙቭ ተደርጎ ይሆናል ሎከሩ
ሊሆን ይችላል። አይ ግን በዛ ሰዓት ላይ ሃፒ ኒው ይር ብሎ የዛሬ ስንት ዓመት እኮ ነው በእውነት ረጅም ጊዜ ነው። እኔ የነበርኩት ብዙ ዓመት ሆኗል። 20 ቁጥር ደግሞ አልታሸገም። ለሴቶቹ አልተሰጠም አይደል? ለሴቶች ተሰጠ እንዴ?
ኧረ አልተሰጠም። አሁን አሉ ሊያውም እዚህ ውስጥ ገብቶ ይሆናል አቅም እንጂ እኔም ፎር ላይክ ዊክ 2 ዊክስ 20 ቁጥር ተመድቤ ነበር።
እና ለምን ለቀቅ? አሪፍ ዶርም ናት እኮ።
በአጋጣሚ ለቀቅ ያ አጋጣሚዎች ነበር።
ለምን ለቀቅ?
እኔ ወደ እንትን ሄድኩ፣ ወደ ሌላ አንድ የተሻለ ዶርም አግኝቼ።
ሴቶቹ ጋር አይደለም ማን ነው እንደዚህ የሞተው? የሆነ የምታውቀው ነገር አለ ማለት ነው። በጣም የኮረኮሯት ያህል ነው የሳቀችው። ብሩኬ
ጊዜው ከፍቷል በጣም
ጊዜ ከፍ
ዜክስ ለአንተ ልክ የላለሁ እኔ እምቢ እያለኝ ነው።
እሺ
ባይዘው የሆነ ሌጀንደሪ ሰው ነበር። አይ ቲንክ ሜቢ ታውቁት ይሆናል። ዘውዲቱ ነበር ለረጅም ጊዜ እና ከውጭ ይዞ ይመጣ ነበር። ሴቶች ይዞ ይገባ ነበረ ዶርም። ሌጀንደሪ ሰው ነው። እጮሃለሁ ምናምን ሲሉት እኔም አብሬሽ እጮሃለሁ እና ገላቸውን ሲታጠቡ ልታገኝ ትችላለህ ዶርም ውስጥ። ብሩኬ ከአንተ ጋር እኮ ነው የማወራው። ሌሎቹ እንደሆኑ ኩራተኞች ናቸው።
ፎቶን እንትን ይነስ
ዶክ በዋትስአፕ ልኬልሃለሁ።
እሺ እስቲ አንብቧት ይችን ጥያቄ።
ይቅርታ ትንሽ የተቆራረጠብኝ ነበር፣ ግን በዋትስአፕ ልኬያለሁ።
አዎ አይ አሁን ጥያቄውን መልሱ። ገርማ 2003 በምንድን ነው 2003? በኢትዮጵያ ነው በፈረንጅ ነው?
አይዲያ የለኝም እንዳገኘት ነው።
ይገርማል። ይችንማ በፍሬም ነው ማስቀመጣት። እሺ በሉ አንዳችሁ ቮለንቲር አድርጉና አንብቡ። አትፍሩ። ብትሳሳቱም ችግር የለውም። አብረን እንትን እንላለን። ጊዜ አትግደሉ። ቶሎ ቶሎ በቃ ጨርሰናል እኮ። እናንተም ወደ መኝታችሁ እኔም ወደ ምሳዬ ብንሄድ
A 43-year-old woman is evaluated in the emergency department for confusion and a 1-week history of yellow skin. She consumes 12 beers daily. On physical examination, temperature is 38.5, blood pressure is 120/50, pulse rate is 100 per minute, and respiration rate is 24 per minute. Her sclera are ectric and the skin is jaundiced. Tender hepatomegaly is present. She has asterixis and is oriented to person only. No source of infection has been identified. Maddrey discriminant function score is 35.
ምንድነው ፕሮብሌሟ? ዳያግኖሲሷን ንገሪኝ እስቲ።
አልኮሊክ ሊቨር ዲዚዝ የሚመስል ነገር አለ።
አልኮሆሊክ ሄፓታይተስ አይመስልም?
የስ
ቀደም ያወራሁት ሁሉ አለ። ሄፓቶሜጋሊ አልኩኝ፣ ፊቨር አልኩኝ አይደል? ሂስትሪ ኦፍ አልኮሆል አላት። ማድሬ ስኮሯ ደግሞ ሲቪሪቲ ስኮሩንም አውርተናል። 35 ነው ይላል። ሲቪር ነው ወይስ ማይልድ ዲዚዝ ነው? ማድሬዋ 35 ነው እንዴ? ተናግሬያለሁ እኮ አሁን። ሲቪር ያ ኢፍ ኢት ኢዝ ግሬተር ዛን 32 እኮ አለ። ማድሬ ዲስክሪሚናንት ፋክተር ሞር ዛን 32 ከሆነ እኮ ሲቪር ነው ስላልን ኢትስ ኦልሬዲ 35 ሂር። ኦኬ ጎ አሄድ።
The lab studies,
Yes.
leukocyte count is 14,000. Prothrombin time is 14 seconds. Alkaline phosphatase is 200 units per liter. Alanine aminotransferase is 30. Aspartate aminotransferase is 62. And total bilirubin is 17 milligram per deciliter.
አሁን AST to ALT ratio ስንት ነው አሁን?
It's greater than 2.
Greater than 2. That speaks in favor of alcohol. Leukocytosis አላት. That also favors in terms of hepatitis, alcoholic hepatitis አይደል? ሊኮሳይቶሲስም ይኖራል ብለናል አይደል? ያልነው ሁሉ ተፈጸመባት። ቶታል ቢሊሩቢንም 17 ነው። ሲግኒፊካንትሊ ኤሌቬትድ ከፈለግሽ ደግሞ አሳይሻለሁ። ይኸው እስከ 1.2 ነው ኤሌቬትድ ነው። ቀጥይሽ።
Ultrasound of the right upper quadrant shows hepatomegaly, minimal ascites, liver echogenicity, and no biliary stones or ductal dilatation. Which of the following is the most appropriate management? Cefepime, liver biopsy, pentoxifylline, and prednisolone.
What is the answer?
Prednisolone.
Excellent. ምክንያቱም ለምንድን ነው ሲቪር አልኮሆሊክ ሄፓታይቲስ አላት። ማድሬዋ 35 ነው። ከእንደገና ደግሞ ኤቪደንሶቹ ሁሉ አሉ። ሊኮሳይቶሲስ፣ ፊቨር፣ ቴንደር ሄፓቶሜጋሊ አላት፣ አልኮሆል ሂስትሪ አላት። ሊቨር ባዮፕሲ አሰች አስፈላጊ አይደለም። the definitive diagnosis is by liver biopsy actually ግን you don't need it you know and other pathologies are excluded. ሰፈፒምም አይደለም ኢንፌክሽን የላትም ሴትዮ። So, prednisolone is the treatment for severe alcoholic hepatitis defined as a Maddrey discriminant score more than 32. Presence of hepatic encephalopathy or presence of hepatic encephalopathy ቢኖር ማለት ነው። እና ቅድም ያወራነው ነገር ነው። እስከ 28 ቀን ነው የሚቀጥለው። if they are responsive you assess them with Lilly score at 7 days at day 7. if they are responsive እና Lilly score less than 0.45 ከሆነ you continue treating them for a total of 28 days ማለት ነው። ግልጽ ነው?
Yes.
ቀላል ነው አይደል? ስትረዱት it is very easy. ወንዶች ተሳተፉ አሁን። አትፍሩ። ወንዶች ናትናኤል፣ አስፋወሰን፣ ብሩክ ናትናኤል አንብብ። አራንዳችሁ ቮለንቲር አድርጉ።
በቃ እኔ አነባለሁ።
እሺ
A 60-year-old male, a 60-year-old man is evaluated at follow-up for elevated aminotransferase level noted on laboratory testing for asymptomatic hepatomegaly. He has type 2 diabetes mellitus, hypertension, and hyperlipidemia. Current medications are metformin, hydrochlorothiazide, losartan, and atorvastatin. He consumes 1 to 2 alcoholic beverages weekly. On physical exam, blood pressure is 143 by 80. Other vitals are normal. BMI is 37. Abdominal examination reveals hepatomegaly, no tenderness to palpation, and no splenomegaly. Alkaline phosphatase level is 180 units per liter. Alanine aminotransferase level is 64 units per liter, and aspartate aminotransferase is 42 units per liter. Platelet count is 250,000 per microliter. Serum albumin and serum total protein are normal. Ultrasound shows normal gallbladder without stones, normal bile duct, and an enlarged echogenic liver. Which of the following is the most appropriate next step for management?
በላ አንብበው
ትንሽ ወደ ላይ ዶክ አንዴ። አይ ወደ ላይ ጥያቄው Okay. A is alcohol cessation. B, discontinuation of atorvastatin. C, initiation of pioglitazone. D, weight loss. ለመናገር I'm not sure.
አንዱን በለው ምን ቸገረ? ጥያቄውም አፕዴትድ ሆኗል። ስለዚህ ብትሳሳትም ችግር የለው።
So the patient has just enlargement of the liver ነው ያለው.
And he's and echogenic liver ነው ያለው. So what does that tell you?
Echogenic liver.
አልትራሳውንድ ላይ ኤኮጀነሲቲ አለ ማለት ነጭ ሆኖ ይታያል፣ ብራይት ሆኖ ይታያል ማለት ነው።
BMI ስንት ነው? 37
አይኔ ነው ባለ እንዳለው BMI 37 ኦቢስ ክላስ 2 ኦቤሲቲ አለው።
Okay. No, ትክክል ነው. I go with the fatty liver disease as well.
እሺ ስለዚህ
weight loss. weight loss.
Excellent. አገኘኸው በቃ። So patients with type 2 diabetes or pre-diabetes and elevated liver enzymes or fatty liver on ultrasound should be evaluated for presence of non-alcoholic steatohepatitis and liver fibrosis. The main stay of management for non-alcoholic fatty liver disease is weight loss. ሪዝኑ ምንድነው? ሌላው ይሄን የሚያጠናክርልህ አልኮሆል ሂስትሪ ያለው ሰውየው ግን አንድ ወይ ሁለት አልኮሆል ዊክ is nothing for man. That's number 1. And number 2 ደግሞ አቶርቫስታቲኑ ነው እንዳትል ሰሰሽን ኦፍ አቶርቫስታቲን ስታቲኖች ያው ሄፓቶቶክሲሲቲ ያላቸው እንደምታውቁት እንደዛ ነው እንዳትሉት for a long duration አቶርቫስታቲኑን ሲወስድ ቆይቷል። ከዛ ፓተርን ኦፍ ኢሊቬሽን ኦፍ ኤስቲኤልቲን ስትመለከት አላኒን አማይኖ ትራንስፈሬዝ 64 ነው፣ አስፓርቴት 42 ነው። ሶ ኤኤስቲ ቱ ኤኤልቲ ሬሾ ኢዝ ሌስ ዛን 1 ቲፒካል የአልኮሆልም አይደለም ሞር ዛን 2 አይደለም። ግልጽ ነው። ሞር አልኮሆል ቢሆን ኖሮ የፓቶሎጂው ዋናው ምክንያት ሬሾውም እንደዛ ይሆን ነበር ማለት ነው። እና discontinuation of atorvastatin ሰውየው was on atorvastatin for a long time, no point. alcohol cessation ያው ብዙ ሰው ቀጣይ ያለው አልኮሆል cessation ነው፣ ግን አልኮሆል አይደለም። even AST to ALT ሬሾውን ስታየው ከእንደገና the amount of alcohol he consumes is less እና ፓዮክሊታዞን መጨመር አለመጨመር ጋር ምንም የሚያገናኘው ነገር የለም። ይሄ ዳያቤቲክ ሜዲኬሽን ነው እና the treatment is weight loss። በቃ እንደዚህ ነው። ቴስት ቴኪንግ ስኪላችሁን በጣም መጨመር አለባችሁ because most of you are aspiring to become international doctors አይደለ? ስለዚህ የግድ ቴስት ቴኪንግ ስኪላችሁ በጣም ማደግ መቻል አለበት። እሺ አንድ ሁለት ጥያቄ እንሰራና እንጨርሳለን በቃ። ሴቶች ጀግኖቹ ሴቶቻችን
I will read the question.
ጎበዝ ቀጥይ።
A 62-year-old man is admitted to ICU for hematemesis. He has a history of cirrhosis due to alcohol use. He undergoes hemodynamic stabilization and initiation of octreotide and antibiotics. Other current medications are propranolol, spironolactone, and furosemide. On physical examination, blood pressure is 104 by 58 millimeter mercury. Pulse rate was 62 per minute, and the respiratory rate was 16 per minute. Ascites is present. Bowel sounds are normal, and abdomen is not tender. Endoscopy reveals large varices isolated to the gastric fundus along the greater curvature of the stomach that have stigmata of recent bleeding. Which of the following is the most appropriate next step in management? A. Abdominal CT with contrast. B. Abdominal ultrasonography. C. Balloon tamponade. D. Band ligation of the varices. I would go with band ligation of the varices since it shows a recent bleeding.
I'm sorry, Melat. Let's see why band ligation is not the answer, okay? Then you are not the only one. You see, 83% I have to be honest with you. I was also thinking of band ligation, to be honest with you. I kept quiet because I was not sure. And now, then እኔም 83% ውስጥ እኔም አንቺም 83% ውስጥ ተገኝተናል. Then we are wrong. And the answer is abdominal CT with contrast. Let's see why they say abdominal CT with contrast.
Okay,
In patients with gastric varices, contrast enhanced cross-sectional imaging should be performed to determine the best treatment ይላል። አየሽ አሁን ኢሶፋጃል ቫሪሲስ አይደለም ጋስትሪክ ፈንደስ ላይ ነው ያለ ጋስትሪክ ነው እንጂ it was not esophageal varices. If it was esophageal varices, most probably they would be the answer. እስቲ ዲ ለምን እንዳልሆነ እንይ። Band ligation is an effective therapy አየሽ for esophageal varices, as well as varices of the gastric cardia, not on the fundus, okay, which extend from the esophagus into the lesser curvature of the stomach. Band ligation is effective in these types of varices because of their predictable anatomy and more superficial location, which permits thorough eradication. In this patient, band ligation is not a good option because varices in the gastric fundus are not amenable to this approach. ተረዳሽው? አናቶሚክ ሎኬሽኑ ነው ያስበላን እና ሲቲ ስካን መሰራት አለበት ይላል። ዲቴይሉን ብናነበው ይነግረናል። ሌላ ጥያቄ እንሞክር። maybe one last question.
Yes.
እስቲ ascites related. እሺ ይሄው ወንዶች ኩራተኞቹ ወንዶች ጋቢያችሁን ለብሳችሁ ጀነን ብላችሁ ቁጭ ብላችሁልኛል። ቀጥል እሺ ወንድሜ።
A 64-year-old man is evaluated in the emergency department for ascites. He has diabetes mellitus and cirrhosis associated with hemochromatosis, as well as a history of hepatic encephalopathy. Current medications are metformin, canagliflozin, lactulose, and rifaximin. On physical examination, blood pressure is 106 by 76 millimeter of mercury, and pulse rate is 60 per minute. Other vital signs are normal. The patient is alert. Jaundice, spiral telangiectasia, and pulmonary edema are present. Jugular venous distension and peripheral edema are present. Cardiac sounds are indistinct and lung sounds are diminished. Ascites is present. Abdominal ultrasound shows the cirrhotic liver, splenomegaly, and abdominal ascites. Biosynthesis with analysis of acidic fluid shows leukocyte count of 100 per microliters, albumin level of 2.2 grams per deciliter, total protein level of 2.6 grams per deciliter, and serum albumin level is 3.5 grams per deciliter. Which of the following is the most appropriate management? A. Acidic fluid cytology. B. Acidic fluid triglyceride measurement. C. Echocardiography. D. Liver biopsy.
Mhm. እሺ
My answer would be I would assume it's acidic fluid cytology.
ኦኬ ሌላ የሚል ሰው አለ? ዋይ አሳይቲክ ፍሉድ ሳይቶሎጂ ለምን ፈለግ? አር ዩ ሰስፔክቲንግ ማሊግናንሲ?
Yeah, maybe acidic. May I make the difference? Serum albumin.
ይህ ሰውዬ ወላዲ ሂስትሪ ኦፍ ሲሮሲስ እንዳለው ይነግረዋል። ሄሞክሮማቶሲስ አለው እና
Maybe hemochromatosis. I guess liver biopsy definitive into ለማወቅ
ኦኬ ሲ የሚሉ አሉ፣ ዲ ያሉ፣ ሲ እና ዲ ሊቨር ባዮፕሲ የሚሉ አሉ። የቱን ሊቨር ባዮፕሲ ነው ያልከኝ አንተ? ያንተን ልምረጥ።
Yeah, definitive diagnosis, I guess. I'd go with liver biopsy.
እሺ ኤኮ ነው። ለምን ኢኮ ይመስላችኋል? ለምን ይመስላችኋል?
symptoms of hepatopulmonary syndrome ስላለው
Do you see this?
maybe
and እዚህም ደግሞ ይሄም አለው። Let's see. So the differential diagnosis of ascitic fluid with a high ሌላው ደግሞ ካልኩሌት ያላደረጋችሁት ነገር አለ። ይሄ ሁሉ ነገር ሲሰጣችሁ for a reason ነው ይሄን ዘርዝሮ የሰጣችሁ። ሳጉን ካልኩሌት አድርጉ እስቲ። ሴረም አልቡሚን ስንት ነው? 3.5 አይደል? አሳይቲክ ፍሉድ ደግሞ ስንት ነው አልቡሚኑ? 2.2 ስንት ሆነ ማለት ነው? 3.5 ሲቀነስ 2.2 ስንት ሆነ? 1.3 አይደል? ሳጉ ስንት ነው? ትክክል ነኝ? 1.3 1.3 1.3 ስለዚህ ዲፈረንሻል ዳያግኖሲስ እዛ ጋር አንደኛው ሲሮሲስ ነው፣ የሀርት ፌሊየርም ሌላው ነው አይደል? ቅድም የሆነ ቴብል አሳይቻችኋል ነበር። ያ ሲሮሲስ ላይ ሌላው የሚረዳችሁ ምንድነው? ቶታል ፕሮቲን ታያላችሁ። ቶታል ፕሮቲኑ ስንት ነው? ያሳይትሱ 2.6 ኖርማሊ ስንት ነበር መሆን የነበረበት? ከ6 እስከ 7.8 ስለዚህ ሎ ፕሮቲን ካውንት ነው ያለው ማለት ነው አይደል? ቶታል ፕሮቲኑ ይኸው እዚህ ጋር ቫልዩን ስታዩት ከ6 እስከ 7.8 ነው። የሴረም ነው ይሄ አክቹአሊ። ሶ ቶታል ሴረም ፕሮቲን is already low. It's only 2.6. ሴረም አልቡሚን 3.5 ነው። ቆይ እንዳልሳሳት አልቡሚን is 2.2 and total protein is 2.6. It's very low. It's supposed to be between 6 to 7.8. ስለዚህ በሀርት ፌሊየር ላይ ቶታል ፕሮቲን ሎ የሚሆንበት ምክንያት የለም። ሲሮሲስ ላይ ግን ሎ ይሆናል አይደል? ስለዚህ እሱንም ኢንቱ ኮንሲደሬሽን መውሰድ አለብን። So the differential diagnosis of ascitic fluid with a high serum ascites to albumin gradient 1.3 ስለሆነ ማለት ነው greater than 1 ስለሆነ includes cirrhosis and non-cirrhotic causes like heart failure አይደል? heart failureንም ይጨምራል። እና ይሄ ሰውዬ ኤሊቬትድ ጄቪፒ ያለው የሚለን እኮ heart failure ኢንዲኬት እያደረገ ነው። እና the total protein level is low in cirrhotic ascites አይደል? less than 2.5 ነው። ስለዚህ less than 2.5 ነው የሚሆነው። ይሄኛው ግን ቶታል ፕሮቲኑ 2.6 ነው። ሶ የምንጠብቀው በሲሮሲስ የምንጠብቀው ቶታል ፕሮቲን ከ2.5 እንዲወርድ ነው የምንጠብቀው። ያ አልሆነም፣ 2.6 ነው። ስለዚህ ሲሮሲስ አይደለም ዲል እያደረግን ያለ ነው። እና ሃይ ካርዲያክ አሳይተስ እና ቶታል ደግሞ ካርዲያክ አሳይተስ ላይ ከ2.5 በላይ ይሆናል ቶታል ፕሮቲን ሌቭል። አወር ፔሸንት ስንት ነው? 2.6 ኖ አም ሶሪ፣ በሲሮሲስ ሌስ ዛን 2.6 ይሆናል፣ 2.5 ይሆናል። በካርዲያክ አሳይተስ ሲሆን ግሬተር ዛን 2.5 ነው ኤክስፔክት የምናደርገው። ሶ ዚስ ፔሸንት ኖርማሊ ሲሮቲክ ቢሆን ኖሮ ሌስ ዛን 2.5 መኖር ነበረበት፣ አልሆነም። ስለዚህ ሲሮሲስ አይደለም ዲል የምናደርገው። ሞር ዛን 2.5 በካርዲያክ ዲዚዝ እንጠብቃለን። ኢትስ ኦልሬዲ ሞር ዛን 2.5 ኢትስ 2.6 ሶ ዊ አር ዲሊንግ ዊዝ አ ካርዲያክ ፓቶሎጂ። ስለዚህ ያንን ዳያግኖሲስ ኮንፊርም ለማድረግ ኤኮ ካርዲዮግራፊ ነው። ኢቭን ሀርት ሳውንዱ ራሱ ኢንዲስቲንክት ነው ይላችኋል እዚህ ጋር። ካርዲያክ ሳውንድስ አር ኢንዲስቲንክት and lung sounds are diminished። ስለዚህ ፕሉራል ፊውዥንም አለው ማለት ነው ዲቱ ዘ ሀርት ፌሊየር። ሞር ዲቴይል እዚህ ጋር ብታነቡ ያስረዳችኋል። ግልጽ ነው?
yes
ያ ስለዚህ እንደዛ ነው። አንድ ልጨምርላችሁ ከሌላ ከኮምፕሊኬሽኖቹ መካከል እና since our patient has hepatic encephalopathy, soon certain we will call it a day unless you want to do more. ሴቶች የሴቶች ተራ ነው፣ መድገም ይቻላል። ብሩኬ we have to come up with that incentive። ብሩክ አለ
አለው
መድገም
ተመልሼ
ከተቻለ አይ ቲንክ
ኢንሰንቲቭ ማዘጋጀት አለብን እና ሰርፕራይዝ ማድረግ ስንጀምር መሻማት ይጀምራሉ። ቀጥይ እህቴ የጀመርሽው።
እሺ a 56-year-old man is evaluated in the emergency department for symptom of progressive confusion for the past 2 days. He has history of cirrhosis due to alcohol use but has been abstinent for the past 5 years. He also has a history of depression and anxiety.
Escitalopram.
Escitalopram is listed. Escitalopram is listed as his only medication on the electronic medical record.
የምን
On
መድኃኒት ነው
physical
escitalopram? What kind of medication is it? SSRI ነው። እሺ selective serotonin reuptake inhibitor ነው። SSRI ነው። የዳያቤት የእንትን መድኃኒት ነው። የዲፕሬሽን SSRI ነው። ቀጥይ።
Okay. On physical examination, vital signs are normal. He is oriented to self, but not time or place. Scleral ectras and the asterisks are noted. The remainder of the physical examination is non-contributory. The specimen are obtained for blood and urine culture and comprehensive metabolic profile. Which of the following is the most appropriate next step in evaluation? CT of the head, electroencephalography, medication review and reconciliation, and neuropsychiatric testing. Okay.
የቱ ይሆን? So most probably what's your diagnosis? መጀመሪያ ላይ የምጠረጠሪው ዲያግኖሲስ ምንድን ነው?
Acute on chronic liver disease.
ግን specifically which complication is apparent in this patient? የኛም patient ይመስላል እኮ
Yeah, hepatic encephalopathy.
ሄፓቲክ ኢንሴፋሎፓቲ ይመስላል አይደል? ስለዚህ በዛ ላይን ላይ አስቢ። የቱን ነው ማድረግ ያለብሽ? ሲቲ ኦፍ ዘ ሄድ፣ ኤሌክትሮኢንሴፋሎግራም። ዲድ አይ ሜንሽን ሲቲ ኦፍ ዘ ሄድ? ለምሳሌ ፕሬዘንቴሽን ላይ ሌሎች ዲፈረንሻል ዳያግኖሲሶች ቢኖሩ ኦፍ ኮርስ ዩ ሃቭ ቱ ዱ ሲቲ። ሌላ ኮንሲደር የምታደርጊያቸው ለኮንፊውዥኑ ኤሌክትሮኢንሴፋሎግራፊ ኢኢጂ ማለት ነው። ሲጀር ዲስኦርደር ቢኖረው ምናምን ኢት ሜክ ሴንስ። ሜዲኬሽን ሪቪው ኤንድ ሪኮንሳይሌሽን ኢዝ ኢት ኢምፖርታንት? ምንድነው ሜዲኬሽኑን ኦልሬዲ ነገረሽ። ምንድነው አለሽ? የሲታሎፕራን ኢዝ ሊስትድ አዝ ሂዝ ኦንሊ ሜዲኬሽን ኦን ዘ ኤሌክትሮኒክ ሜዲካል ሪከርድ ይላል። ሞስት ፕሮባብሊ ሌላ ላይኖረው ይችላል። ኒውሮሳይካትሪክ ቴስቲንግ አሁን ኢት ሉክስ ላይክ ከሁለቱ ይመስላል አይደለ? ሜዲኬሽን ሪቪው ኤንድ ሪኮንሳይሌሽን እና ኒውሮሳይካትሪክ ቴስቲንግ። ሜዲኬሽን ሪቪው ኤንድ ሪኮንሳይሌሽን ከሆነ ኢሲታሎግራም ብቻ ነው ሊስትድ የሆነው ብሎ ኢንፎርሜሽን ነግረውናል እዛ ጋር። እና ደግሞ የዲፕሬሽን ሜንቴሽንን ዲፕረስ የሚያደርጉ ነገሮች ናቸው አይደል? ለሄፓቲክ ኢንሴፋሎፓቲ ፕሪዲስፖዝ ሊያደርጉ ይችላሉ ያልናቸው ቅድም ስናወራ ሰው እና የቱን እንበል? የመራው ገደል ይዤሽ እንዳልገባና እንዳልስቅ በራሴ ላይ
I would go with C because for neuropsychiatric testing, he has more symptoms like ecteric sclera and asterixis. That wouldn't be explained. C.
እሺ እኔ የለሁበትም። እኔ እንደውም ገፋፍቼሻለሁ ሌላ ነገር እንድትይ። Excellent. I was tricking you. So medication review and reconciliation. Reason being, even though, SSRI ብቻ ቢሆንም ሊስትድ የሆነው you never know ሌላ የምትወስደው መድኃኒት ሊኖር ይችላል። ሪሰንትሊ የወሰደችው ሌላ ሜዲኬሽን ሊኖር ይችላል። ፕሪሲፒቴት ያደረገው ሄፓቲክ ኢንሴፋሎፓቲን አይደለ? you never know አሴታሚኖፌን ወስዳ ሊሆን ይችላል። ወይንም ደግሞ ሜንቴሽንን ዲፕረስ የሚያደርግ ኤኒ ሜዲኬሽን ወስዶ ሊሆን ይችላል። ወንድ ነው እና you never know. You have to reconcile. Medication review and reconciliation is very important if it is any precipitate የሚያደርገው እሱ ከሆነ The first step in the evaluation of hepatic encephalopathy is identification of precipitating factors. እና common precipitants are like infection, አይመስልም ምንም GI bleeding, historically ምንም የለም። አልኮል እየወሰደ አይደለም፣ አብስቴን አድርጓል። Medications with sedating properties such as benzodiazepines and opioid analgesics መኖር አለመኖራቸውን እርግጠኛ መሆን ማለት እነ ዳያዜፓም፣ አልፕራዞላም ምናምን የሚባሉት እና ሾርት አክቲንግ ቤንዞዲያዜፒንስ እና any opioid medications, narcotics, they depress your mentation። እሱ very important ነው። ግን ለምን ኒውሮሳይካትሪክ ቴስቲንግ አይሆንም የሚለውን እንመልከት። what is the rationale? Minimal manifestations of hepatic encephalopathy can be detected on neuropsychiatric testing. Minimal defines the disease as having no clinical signs of encephalopathy, such as confusion or asterixis መኖር የለበትም። ያኔ ነው neuropsychiatric testing is of value because it can help predict the development of over hepatic encephalopathy, indicate poor quality of life and reduce socioeconomic potential, and help counsel patients and caregivers about the disease. Neuropsychiatric testing will be of no value in this patient with overt encephalopathy. That's the main reason. So the patient has already developed overt encephalopathy with signs of asterixis, confusion, disorientation. So neuropsychiatric eval is for patients with minimal manifestations of hepatic encephalopathy. Okay, not with overt hepatic encephalopathy. So you have to reconcile medications and see if there is any predisposing medication like sedatives, narcotics, and all that. I think we had a very fruitful discussion. I think it's enough. And thank you so much, guys, for participating. And now, if you have any comments, I will open the floor for I hope I recorded it, right? Oh my God, I was going to freak out. So I will stop recording and then,